A very good evening, everyone. A very good evening, everyone. Right now, I think I'm audible, right? Right. So again, a very good evening, everyone. Hope your preparation is going really good. A very good evening. Right. So welcome to the Mental Health Nursing NORCET Recall session. Let me know in the chat box now. I hope I am audible now. I hope the voice is now coming. Yes. Right. Great. So I hope the preparation is going really good, and again there might be some nervousness, but that's okay, that's normal. So let's start this session. Again, in this session what we're going to do is we're going to have a very quick rapid fire round of session. So again, good evening. And what we are going to do is I'm not just going to discuss one or two paper. Let's discuss some of the important questions from previous NORCET exams, and also I'll discuss some newer questions also, so that we get an idea. Just the exam is nearby, so that we get an idea what type of questions are asked, or how questions may be framed if new questions are also asked. So let's discuss, let's start this session, right? Before starting, again, very interesting and very something very major occurred, that Sunita Williams along with Butch Wilmore, they returned from space, nearly after 9 months. Their journey was for few days only, but because of certain technicalities they had to spend nearly 9 months in space. And one of the very famous quote of Sunita Williams is, don't get bogged down by the notion of limits. There aren't any limits. Please remember this. So please remember, anything is possible. Try to continue doing really good work, and you'll see the exam is around the corner. You'll do really well in the exam. So don't think that I cannot do. Just keep on studying well. So I'll again come back to this point again. We have been discussing this again and again, that these are the important topics. So I'll just roughly discuss, I'll tell you again, so that you have an idea about these important topics in mental health nursing. So we'll talk about questions from basics, especially we'll talk about questions being asked from MSc, again a very important area. Organic mental disorder again is one of the areas we'll discuss. Schizophrenia, if you ask me, again a very important topic, schizophrenia and other psychotic disorders. Then there are mood disorders, depression, bipolar disorder. This is the neurotic disorder spectrum which we discuss. We'll discuss some of these important topics, such as anxiety disorders, PTSD, OCD, again very important. You'll see, recently in the last exam 2 questions came from OCD. We'll also cover one important topic from somatoform related disorders. Then there are smaller topics like child psychiatry. Another important topic is substance use disorder, again very important. We'll also discuss some of these topics such as eating disorder, and of course we'll talk about some of the other miscellaneous topics including ECT as well. So let's start with the session. Let's have a quick rapid fire round of questions. So this is the first question. So let's answer this question. The question is related to mental health. Again, sometimes when such questions come, try to see all the options, very important. Look at all the options, try to rule out the other option, and you'll get to the right answer. So tell me, what is the correct answer of this question? Again, a good evening to everyone, right? So let's start this discussion. So tell me, what is the correct answer? What is mental health? The ability to distinguish what is real from what is not. Again, reality testing usually helps us differentiate neurosis and psychosis. What is the right answer here? Again, yes, this is a definition by World Health Organization. Very good. So what is mental health? It's a state of well-being where a person realizes his or her own abilities to cope with the normal stresses of day-to-day life, is able to work productively, and is able to contribute to the community. So this is very good. The answer is right. So this is mental health. Very good. It is not just absence of mental illness. So very good. All of you are correct. This is the correct answer. Let's come to the next question. A 40-year-old male patient is brought to the psychiatric clinic with the illness since 10 years. So see, again, whenever you are solving such questions, now please look at the durations also. Durations are very important. Family members report that when any happy event or sad event occurs at home, he shows no emotion. So can you appreciate? First, let's try to understand what is the topic we are covering here. So what is the, so we are seeing on his facial expression, any, happy event comes, any sad event comes, but there are no changes in emotion. So can I say we are talking about affect? So please try to appreciate in the question what type of, question it is being framed from. So they're talking about affect. So tell me, what is this abnormality of affect, that there is no change in them? Very good. So we always talk about this, remember things from the name, flat affect, as if the emotions are dead. Very good. The answer is C, flat affect. Flat affect means there is no changes in emotion. Tell me one condition, one important condition where you may find flat affect. I'm sure all of us will be able to tell this condition. So quickly, you can also think and answer about these questions also. So again, it may be seen in schizophrenia. Very good. Also known as blunt affect. Remember, it is one of the negative symptoms of schizophrenia. Such question may be asked. That flat affect is which symptom of schizophrenia? It is not an affective symptom of schizophrenia. It is one of the negative symptom of schizophrenia. Also remember, what is labile affect? What is labile? Labile means something which is changing. So patient without any reason is laughing, then he starts crying. So this is lability. Again, remember two important conditions, mania, you call it mania, or we can call it bipolar disorder, and even organic mental disorder. Very good. Yes, very good. We'll talk about A's. When we say A's, we usually say Bloyler's 4A's. So don't confuse, again, negative symptoms of schizophrenia, we have also discussed, they are also starting with A. But please remember, when we say 4A's, 4A's, it is also there in 4A's of, Bloyler's 4A. But please remember, Bloyler 4A's is different, negative symptoms is different. Yes, there also we'll discuss. So I hope the answer is clear to everyone. It is flat affect. Right, so thank you very much. Again, let's see this question now. Again, look, I am also discussing some older questions also, so that you get an idea. Questions sometimes are not very difficult. Always read the question, read all the options, and then try to answer. Now tell me the answer. What is the right answer of this question? What is the following term is used to describe lack of interest in pleasurable activities? Patient finds no interest or decreased interest in activities which the person would enjoy before. Person would say, I would enjoy watching movies, I would enjoy doing shopping, but nowadays the interest is reduced. What is the very good? The right answer here is anhedonia. Very good. It is anhedonia. Very good. What is perseveration? I hope everybody understands, remembers perseveration. Perseveration we discussed. Perseveration is the person is repeating same words again and again. So perseveration is a problem of thought. Again, alexithymia patient says, I'm not able to understand or express my emotion. Avolition is decrease of will or decrease of motivation. So here the right answer is anhedonia. Very good. All of you are correct. Let's discuss the next question. Again, see this. A very interesting question. A patient presents in the emergency. So patient has come to the emergency with personality changes. So there are some personality changes in the patient. Which of the area of the brain is most likely affected? Again, in fact, when we talked about the topic of organic mental disorder, we've talked about this question. So look at this question. Now this is more of a clinical question. Very good. Yes, all of you are answering correctly. Very good. Tell me what is the right answer. So such questions may come. Suddenly the patient has come to the emergency. So there might be some injury. Maybe let us say there is a head trauma. After that, patient has developed some personality changes. Okay. So which area is affected? Now this is, yeah. So we are live here right now. We are live. Don't worry. We are live. You can answer. I'm seeing your answers. Right, the correct answer is very good. It is frontal lobe. So let me discuss some important points. Again, when frontal lobe is affected, you may see, we already know, when we're talking about the basics, we know that frontal lobe regulates emotions. So again, emotional disturbances can occur if frontal lobe is affected. Also remember, personality changes can occur. If frontal lobe is affected, family members may report that the personality is not the same. Also remember, this is again an important question, which you should remember, disinhibitory behavior. So let us say a patient goes in public and starts urinating without any guilt. So he, there are certain inhibitions, certain behaviors which we don't do. We inhibit ourselves from doing those behaviors, like in public, you would not urinate in public. But if frontal lobe is affected, those inhibitions are gone. So there are disinhibitory behaviors. So such question may be asked, which area is affected? So again, remember, it is the frontal lobe. Very good. I hope it is clear to everyone. Now see this. This is one of the topics you are seeing again and again. I have also brought some questions which are slightly controversial. I've been seeing again and again those queries, so we'll discuss those as well. So let's discuss a very important topic. So this topic is under thought. So let's discuss under MSc one very important topic. So there may be problems in the thinking. So tell me the answer. Tell me the answer here. A person is saying his family members are dying. He is also decaying. Nothing exists in the world. So can I say that patient in his mind, he has developed a false, fixed, firm idea or belief held with extraordinary conviction. So I'm sure all of us know this is a delusion. Very good. So which delusion are we talking about? Very good. The delusion is, it is delusion of nihilism. I'm sure now we can, differentiate these delusions. Persecution, when the patient says somebody is planning to harm me or kill me. A reference, very important. Reference means patient thinks things around him are occurring in reference to him, like people are talking about me. somebody spying on me. Grandiosity, patient make false big claims, I am the king of the world. False big claims the patient may make. And delusion of nihilism is this, where the patient is denying the existence of his body, of people around him, or the entire world. Very good. So can anybody tell me what is Cotard syndrome? Very important. Very good. So I hope this term is also very clear to you. Cotard syndrome, you know, this term is used in literature when a patient, so please remember, delusion, we know it's a psychotic symptom, again can occur in various conditions, psychotic disorders, even other conditions. So remember, Cotard syndrome is when a patient with depression, he develops delusion of nihilism, right? So please remember these terms. So right, all of you are very correct. The answer here is option D. Let's see, you know, again, you know, previously this was asked, you know, in 2021, again a question from this topic. See this question again. Very good. Yes, patient with schizophrenia think he is in danger, somebody wants to harm him. I hope the answer now is very clear. The answer here now is yes, the answer becomes very clear now. The answer here is delusion of persecution or delusion of persecution, right? D, option C. The answer is C. I hope this is clear to everyone. So please see this again. In fact, see one more question. Again, you will see so many questions. Very good. Schizophrenic. So see the question. They are telling you the diagnosis is schizophrenia, who is experiencing thoughts of having special powers, states that I am a messenger from another planet and can rule the earth. The nurse assesses this behavior as. So please see this again. You know, patient is claiming such, you know, false big claims the patient is making. So tell me what is the answer here. So tell me the answer here. Very good. Really happy to see all the students answering correctly. Yes, it is delusion of grandeur. Very good. Or delusion of grandiosity. Again, remember, you know, sometimes these delusions can also occur in other disorders like mood disorders. You know, sometimes you may find delusion of grandeur may be seen even in disorders like mania. Even in mania, patient may have psychotic symptoms such as delusions, hallucinations. You know, so such delusion again may be seen. Okay. Now, please remember, when we say ideas, you know, when we say ideas of reference, let's make it very clear here only. When a person is having a delusion versus when a person is having ideas of reference, let us compare delusion of reference with the ideas of reference. So please remember, in delusion of reference, it's a false, fixed, firm belief. So here the belief is totally fixed. No matter what you say, the patient is totally convinced. But when we use this term ideas of reference, it means that this belief is not fixed as a delusion. So somebody having ideas of, you know, reference may say, I think maybe people are talking about me. So he may not be that much fixed in that belief. So please remember, I hope this term is clear to everyone, because we know we'll discuss one question, right? Very good. Right. So yes, correct. So let's see, we'll discuss some of the diagnosis. We'll talk about that. Now tell me this question. Now this is one interesting question. What is the meaning of schizophrenic patient saying that someone is sending him secret message while watching television? Again, very interesting. Now this is again has been asked. Now please see this. Now again, I can say this seems to be, you know, the patient thinks that things around him are occurring in reference to him. It is not hallucination. It is not illusion. It's not a problem of perception. We'll discuss hallucination, illusions. These are problems of perception. Now it seems to be a delusion. Here again, you know, they've given a diagnosis also. The patient has schizophrenia. It is not telling us that, you know, it is not a fixed belief. It is, you know, telling us it is probably a delusion of reference. Again, please see the option. So better answer here would be delusion. Please remember, ideas of reference, you know, if that is not given, then maybe you could think of ideas of reference. But delusion is an option which is given. It seems to be delusion of reference. It seems to be a fixed belief. I hope this is clear to everyone. You know, I hope this is clear to everyone. You know, I've been seeing such doubts. So please understand, you know, so we have discussed what is ideas of reference. So here, you know, the diagnosis also they've given. So it seems that patient is having delusion. You know, he thinks somebody is sending him secret message while watching television. Okay, so this is delusion. The answer is option B. Very good. Yes. Now see this question. Now again, such questions may come. A 42-year-old woman is seen in emergency room after she was brought in for starting a fight in a bar, and during the interview she answers questions, you know, nearly continuous flow of accelerated speech. So please try to identify these terms in the question. The patient is having a very increased rate of speech, jumping from topic to topic. For example, you know, one sentence they mentioned, like the patient says that I am fine, are you fine, does the sun shine, it is outside, it is night now, nice outside today. The Today Show is very interesting place to be. I will have to be, I will have to run it. So can you appreciate patient is saying so many things very fast, not making much sense, but there is some connection. Very good. The answer here is, can anybody tell me? Yes, it is flight of ideas. I hope all of us, know how to identify flight of ideas. Again, when we divide thought, I hope all of us know this classification. We divide into these 4 headings: flow, content, form, possession. Flight of ideas, patient saying things very fast, things may not be making sense, but there is some connection. By chance connection, I always give this example: मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे तुझे ही तो ढूंढे, something like this. Or there may be some connection by clang association, the words may be rhyming. So this is flight of ideas. Very good. Again, tell me one important condition where you see flight of ideas. No, but please see this. The question, the answer is not hallucination. Hallucination is, the TV is actually there. He is actually watching television. There is someone on the screen. So it's not a hallucinatory phenomenon. It's a problem in his thinking. So that is why I said, always try to rule out the option, then you'll come to the answer. Here they're not saying that there is no TV, but he's watching a TV. If there was no TV, but he's seeing a TV, then that would be a hallucination. Here he is watching TV and there is some false thought which has come in his mind. I hope this is making sense. It is clear to everyone. You'll be able to differentiate a delusion from hallucination. Very good. Yes, the answer is flight of ideas can be seen in mania. Very good. Yes, all of you are correct. Now, I'll just quickly show you this classification. Again, I hope all of us are very clear about this classification. So under flow or stream of thought, we have discussed flight of ideas, perseveration, even circumstantiality we have talked about. Patient gives unnecessary trivial information, but he reaches the goal. The goal is reached, right? Content, remember one very important abnormality, that is delusion. Under form, form means there is disorganization. There is disorganization of thoughts. I hope all of us remember some of these important abnormalities like loosening of association, derailment, on track changes the track, tangentiality, touches the topic, goes away, neologism, uses new word. And under possession of thought, remember one is obsession and another is phenomenized thought alienation or passivity of thought. That is thought insertion, withdrawal and broadcast. So just a quick overview because this is a very important topic, so please remember this, right? Very good. Okay. I hope this is clear to everyone, right? I hope this is clear, right? Sanjay, sometimes patient may have somatic delusions also, sometimes delusion may be related to the body parts. So please remember, sometimes patient may have, if it's a false fixed firm idea or belief held with extraordinary conviction, then we call it as a delusion. See this question now. So see this question. We'll discuss, we'll come to, when I'll come to those topics now, then remind me of those questions. Okay, let's first cover this. See this question again, it's a PYQ. I'll discuss, Ashutosh, in the end I'll discuss some points. We'll discuss especially in the exam day, how to approach the exams. So we'll discuss. Let's try to solve this question. A young girl hears a gunshot, so she's hearing something. Please understand, it's a perception in the neighboring house, but realizes it's the neighbor's grass cutting machine which is making noise. So can you appreciate, there is it is a false perception. It's a problem of perception. So we can easily rule out it's not a delusion we are talking about. Very good. So there is a real object and the person is misinterpreting it to be something else. So this is basically very good. It's a illusion. Very good. It's a illusion. So what is illusion? It's a false perception with a real object. For example, the person see a snake under the bed. When the person switch on the light, he sees, oh, actually it was a rope. So this snake is a false perception of a real object. Like in this case, the real perception is the grass cutting machine and the person is misinterpreted to be a gunshot. So this is very good. This is illusion. Very good. Now see this question. See this question. 56-year-old man has been hospitalized for myocardial infarction. One day after admission, he becomes tremulous, anxious and tachycardic. Several hours later, he begins laughing and pointing to the butterflies that he sees flying around the room. So can I say that person is seeing something again? Always try to identify the problem, what problem the person may be having. So this is again something which the person is perceiving. This is a problem, perception. When the nurse enters the room, she sees no butterflies. So actually there are no butterflies. The misperception of reality is best described by which of the following psychiatric term? So tell me. There are no butterflies, but the person is seeing butterflies. Very good. It is Right, the correct answer it is hallucination. So please remember, hallucination is a false perception. There is without any real object. Very good. Please remember this. Now also, can I say it's visual hallucination? Visual hallucination, one very important point. So we know there are 5 types of hallucination, that is auditory, visual, olfactory, gustatory, and tactile. We know these are the 5 important types of hallucinations we have discussed. Of course, there are some special also. So can anybody, tell me one of the important, so we know hallucination again is a psychotic symptom. It is a psychotic symptom, can occur in psychotic disorders like schizophrenia. Can anybody tell me the diagnosis in this case? Visual hallucination is there, and see, they have been giving you some, some history of MIs there. Also, there are tremulous, anxious, tachycardic, some physical symptoms are also being mentioned. Again, within a few hours, the patient has developed this. So can you think of a diagnosis? Very good. Yes, very good. We know visual hallucination, when we talk about, we say in organic mental disorders, again, visual hallucinations are common. So, it may be a organic mental disorder, of course, such as delirium. But of course, for making a diagnosis of delirium, very important, we'll discuss, there should be impairment of consciousness. But again, something like an organic disorder is coming to my mind when I see this clinical scenario. Very good. Yes. Of course, delirium, I'll say only when they've mentioned the symptom of delirium. But yes, all of you are in the right direction, because it has a acute onset. Very good. So very important, please remember this. Also, I hope, let's just differentiate one more point. So can you tell me the difference between hallucination and pseudo hallucination? Let's complete this. Pseudo hallucination is also an abnormality. Yes, in psychotic disorders, auditory hallucination is more common. Yes. Can anybody tell me how to differentiate? Last question, hallucination versus pseudo hallucination. Remember, hallucination is occurring in the outer, objective space, while pseudo hallucination is occurring where? It is occurring in the inner subjective space. Please remember this. The difference is, where it is, the patient it is experiencing. The patient hallucination is experiencing outside, while pseudo hallucination he is experiencing it in the mind's eye, in the inner space. Right. I hope this is clear to everyone. Very good. Let's see one more question. What is the name of the condition? So I hope now this is again, again a very similar question was, asked. Again, let's try to understand this also. Don't confuse this with, again, let's answer this, then I'll tell you, let us see if we can answer this question again. Sundowning is seen in delirium. Very good. Sundowning means, the symptoms, they worsen in the evening or the night time. Very good. As the sun goes down, the symptoms increase. Very good. That was correct. Tell me the answer again here. I hope again don't be confused. See, it is not thought broadcast. Again here, can you appreciate the patient, thinks that while watching TV, say that anchor shared some secret message with him. He is again having a false belief. Thought broadcast, he will say in thought broadcast, he will say that his thoughts are getting broadcasted outside. He would say that maybe on television, my thoughts are getting broadcasted. So can you appreciate a very similar question, again asked recently, but they've just changed the options. Thought broadcast would be when he says that his thoughts are getting broadcasted outside. Here, his belief is that the on television, somebody has shared secrets with him. So things around him are occurring in reference to him. Again, this is more suggestive of delusion of reference. I hope this is clear to everyone. Please be very careful about these options. Try to be very, clear about the basics, and you will solve the question. I hope again it is clear to everyone. So here, in thought broadcast, he would say that his thoughts are getting broadcasted outside. Here he is not saying this, na? I hope this is clear. Yes. Now see this question again. Now we have discussed all these points. I hope this is a very clear question, very simple question now. A patient admitted in the hospital refused to eat food on the second day after eating on day 1. He claimed that the food is poisoned. So again, I hope this is clear. Gaurav, again, I'll more be in favor of delusion. It seems to be more of a fixed belief. Nowhere they have mentioned. If delusion is not there, then you can think of, that. Yes, Gaurav. If delusion was not given, then you might have thought of. But it is not thought broadcast. Please remember, thought broadcast is saying my thoughts are getting broadcasted outside. Everyone is able to know my thoughts. Okay. I hope this is clear. This is delusion of, yes. This is delusion of persecution. Yes. To make a diagnosis of schizophrenia, we know according to DSM-5 it is 6 months, and according to ICD-11 it is 1 month, right? Now let's see one more question. A nursing officer during the mental status examination, such questions may also be asked. you know, in the MSc, client is asked, you know, to explain similarity between an apple and an orange. Can you tell me what function is being assessed here? Again, very simple, I hope. You know, you're asking a similarity, tell me a similarity. So there are two tests. In fact, let me write those tests so that, you know, again, you could reach to the answer more easily. So let me write down the two tests which we do in this function to assess this function. One is the proverb testing. We ask a proverb, you know, muhavra पूछते हैं, and one more is, as it is mentioned, we ask about similarity testing. Now, can you tell me what is being assessed here? Very good. Yes, the answer here, yes, all of you are correct. We are checking abstract thinking. You know, abstract means, thinking means ability to understand hidden meanings or to form concepts. So we ask, you know, by asking proverbs or by asking similarities. And can anybody tell me, if the abstract thinking is lost, what is this known as? Loss of abstract thinking. Can anybody tell me what is the term we use when there is a loss of abstract thinking? What is it known as? What is it known as? Please remember, for judgment we have discussed, judgment is of various type, like test judgment. In test judgment, again, we give some imaginary situation to the patient. Please remember, let's not confuse here. It is abstract thinking. I hope this is clear. Very good. Yes. When we say abstract thinking is impaired, it is known as concrete thinking. You know, see the name, concrete thinking. Patient is not able to understand the deeper meaning, only superficial meaning. So this is when abstract thinking is absent, it is known as concrete thinking. I hope this is clear to everyone. Right, I'm very happy you are answering it well. Now see this question. See one more question. In the MSc, a resident asked a 30-year-old patient admitted in psychiatry ward whether she is having any illness. Can you tell me what is being assessed here? When I'm asking a patient, you know, do you have any illness or not? Tell me what is being assessed here. Can anybody tell me what is being assessed here? So, you know, I'm trying to ask whether the person is aware about the illness or not, isn't it? Yes, the answer is. So what is being tested? We are asking about the awareness. Yes, the answer is, it is, we are checking insight. You know, again, we know we have discussed, you know, sometimes we divide it into neurosis and psychosis. In neurotic illness, we say the insight may be present. In psychotic illness like schizophrenia, we may say that insight may be absent. Yes, so it is insight which is being tested. So insight basically means awareness of illness. I hope this is clear to everyone. Right. Okay. I hope this is clear to everyone. Yes, Lavanya, sometimes we can also ask comparison also between two objects, you know, because we have to find, you know, whether the person's abstract thinking. Yes, sometimes, you know, difference may also be asked. Yes, but usually, you know, these are the two tests which we can remember. One is the proverb testing, another is similarity. Even differences also can be asked. Yes, I hope this is clear. Yes, you know, now let's see this question. Now, how often is the MSc conducted? Let's see this question. Yes, I mean, if any question which is able to tell me the, you know, whether the person is able to understand hidden meaning, even in differences also it can be asked. Yes, those are also performed. Now, tell me what is the right answer there. Now, you will see usually MSc, you know, how often we conduct it would depend on the setting, you know, whether it is a inpatient, whether it is a outpatient setting, whether it is ward, it is ICU, and also it will depend on the severity. But usually you will see, you know, can you tell me? Yes, usually you see that every day you will do an MSc, you know, of course we may not do a detailed MSc every day, but you will see every day it is conducted. Maybe in more severe patients, we may do it more often, maybe, you know, every 6 hourly. But again, such question may be answered, you know, we'll do it, you know, every 24 hours we'll do it, right? So better answer here would be 24 hours. I hope this is clear to everyone. So these were some questions from the basic. Again, you will see many questions being asked. Delusion, hallucination, these are very important topics, so one has to be very, you know, thorough about these topics, and always try to rule out the option and you will reach the answer. So let's just briefly discuss this one more slide. You know, we always say this old classification, you know, psychiatric disorders can be divided into organic disorder, where there is a visible, you know, apparently visible causes there, like delirium, dementia, and functional disorders we say when there is no visible cause, you know, so there is no apparent cause may be there. So that is further divided into neurosis and psychosis. So let's discuss them again. You know, always try to remember these headings so that when you are solving questions, you know what type of disorder you are seeing in the question. So let's discuss few questions on this. So answer this question. Okay. Yes, I hope this is clear. But again, inappropriate affect means when the affect is not matching with the situation. Patient goes to a funeral, everybody is sad, but he starts laughing. So it's not matching with the situation. It is inappropriate. Incongruent means the affect is not matching with the mood. Patient says, I am very sad, but he's laughing. So can I say that the affect is not matching with his mood? So that is incongruent. Answer this question. नहीं बेटा प्लीज correct it, नीरज. हाँ, answer better would be, that answer would be 24. हाँ, what is the answer here? Most commonly encountered acute organic mental disorder, you know, I'm sure now. Yes, so organic mental disorder, you know, most common organic mental disorder is delirium, and we know delirium has a acute onset. Very good. Now just try to understand this slide, very important. Delirium is a very, you know, important topic. It's a organic mental disorder which is now in DSM-5 and ICD-11, now they're known as neurocognitive disorder. In delirium, in these neurocognitive, as the name suggests, there is cognitive impairment, yes, but please remember, to make a diagnosis of delirium, please see there is impairment of consciousness. So few points you can again remember quickly, you know, that may be mentioned in the question, that may tell you that the consciousness of the patient is impaired, like clouding of consciousness, or it may be mentioned that there is altered sensorium. Patient is disoriented to time, place, person, or there is confusion. Again, these points are suggesting that there is impairment of consciousness, and also there is impairment of cognition, like memory is affected, you know, even language may be impaired. So cognitive functions are also affected. And of course we have discussed, you know, hallucination, like visual hallucination may also be seen. So please remember, this is one very important point we'll discuss even when we'll talk about you know, delirium tremens in alcohol. Look for impairment of consciousness to make a diagnosis of delirium. Now see this one differential diagnosis I want you to remember. A patient has acute onset of symptoms suddenly, let us say few days, fever की history है, patient को delusions, hallucinations present हैं. Can anybody tell me यहाँ पे diagnosis क्या है? तो मतलब ये picture is looking very similar to delirium ना, but यहाँ पे impairment of consciousness is not mentioned ना, so it is not delirium. So tell me, you know, very good, yes, it is acute psychosis. Very good, it is acute psychosis. Acute psychosis means symptoms are similar to schizophrenia but duration is less. Yes, so please remember, fever may also be seen. So please remember, it is acute psychosis. Somewhere if this is mentioned that consciousness is impaired, then my diagnosis would change to delirium. I hope this is clear to everyone. But I'll come to ECT. Then you can ask me all those questions. We'll discuss. Absolute, no absolute contraindication is a better answer. There is no absolute contraindication. Yes, see this. Now answer this question. This was asked again previously. All of the following are results, you know, result in delirium except. Now please remember, you know, delirium may have various causes. In fact, we have discussed, you know, with the mnemonic also, delirium also, with the, you know, name also, you can see, remember some of the causes, like drugs can be there, you know, so many causes may be there. There can be liver causes, there can be, you know, CNS causes. So there may be some physical or there may be some medical cause. So the question is, which of the following results in delirium except? The answer is, you have to choose the except term. Please see this. You know, these questions, when you answer, you know, get to the answer, now you'll see these are very easy questions, but sometimes we are confused. Benzodiazepine withdrawal, just like alcohol withdrawal, benzodiazepine and alcohol very similar, you know, seen as depressant. It can also cause delirium tremens. Opioid withdrawal uncommon, but yes, it may be also associated, usually not seen, but sometimes may be seen. Hyponatremia, again we have been discussing, you know, low sodium, especially sodium levels below 130 patient may present with delirium. Yes, depression we have discussed, it's a functional disorder, you know, you will not associate it with delirium. Please remember, you know, if you know that classification, again very simple to answer such question. Usually, you know, in those functional disorder, you will not see there is impairment of consciousness. So the answer here is option D. You know, if you know that classification also, you know, such question will be solved. Now, few nursing intervention I'll discuss related to delirium. You know, very important to keep the environment safe. Safety of the patient is very important. Patient is confused, patient may injure himself. So physical support should be there. You know, patient should be under observation. There should be someone around the patient. You may shift the patient's bed near the nursing station. When we talk about sensory stimulant, it should be neither too much, you know, like so much loud noise is there, too much of bright light is there, neither it should be too less, like there is completely darkness. So it should be, you know, moderate. Familiar person pictures around should be there, so that because patient is confused. Regular orientation should be done. You know, a clock can be placed near the patient, calendar may be placed, patient may be placed near the window. The patient knows when it is morning, when it is night time. So these are some important points which you can remember. Yes, sundowning is you know, may be seen in delirium. Yes, many of you are mentioned. Yes, it is correct. See this question. Now let's talk about schizophrenia, one of the topics which you will see many questions. In fact, in history many questions have been asked. You know, a Swiss psychiatrist coined the term schizophrenia and replaced the old term dementia precox. Dementia precox was coined by Kraepelin. Who coined the term schizophrenia? Tell me the answer. Yes, Omar. If yes, so TV, because patient is confused, patient may not be able to focus on TV. Yes, you may switch off. The answer is, tell me the answer. What is the right answer? Who coined the term schizophrenia? Very important. I hope everybody remembers. Yes, it is Bleuler. Bleuler is the person who coined the term schizophrenia. Again, it is derived from two words. Schizo means split, phrenia means mind. Tell me one more contribution of Bleuler. In fact, there is another question. Let's see this question also. So you will see a lot of PYQs with such question, which of the following represent 4A's symptoms of schizophrenia. Now, when we say 4A's, it is Bleuler's 4A's. Please remember this. I told you this in the beginning. So tell me, what is the answer here? Yes, all of you are correct. The answer here is Bleuler. See, one more question. So we know Bleuler, Bleuler again, he gave 4A's. Tell me which represents the 4A's. Tell me which represents the 4A's out of these options. You may get such options. Don't worry, read the question, options carefully. When you read such, alogia, when you read circumstantiality, that is not there. Negativism, that is not there. Now again, alogia is not there. So what is the right answer here? Very good. All of you are correct. Yes, it is. These are, option D is correct. So there is association disturbance such as loosening of association, affective flattening. Yes, remember we discussed autism. And also remember even ambivalence. So these are Bleuler's 4A's. I hope this is clear to everyone. Yes. So see, many questions. See, one more question. Again a question, a PYQ. According to Schneider, all of the following symptoms in schizophrenia are known as first rank symptoms except, see this question. In fact, I'll modify this question also. I'll try to modify. So you have to first tell me which is not seen. So you have to tell me which is not seen here. So tell me what is the right answer. Now I hope the question is clear. So which is not seen? Tell me the right answer. We'll discuss Schneider's first rank symptoms. There are 11 symptoms. Very good. Very good. It is visual hallucinations are not there. Very good. Yes, the correct answer is this. In fact, these are the Schneider's first rank symptoms. Can you appreciate the first three symptoms? They are related with auditory hallucination. Also remember, not all auditory hallucinations are, first rank symptom. Only these, three particular auditory hallucination. Then the thought alienation phenomena or passivity of thought. Then three made phenomena. You can remember it with the mnemonic IFA and somatic passivity and delusional perception. Again, we have discussed all these symptoms in great detail. So please remember, sometimes such question may be asked. I hope this is clear. Also remember, if there is one more option, let us say there is an option E is there, which is again a SFRS. Then if visual hallucination is there, then you may think of even auditory, because person, not just any auditory hallucination would be an SFRS. Only these three particular, that is audible thought or thought echo, which is first person, voices discussing about the patient, running commentary. These are the three specific auditory hallucinations which are the part of SFRS. I hope this is clear to everyone, right? So always try to see the option and then come to the right answer. Don't jump to the answer just by seeing one or two options. See all the options, then come to the right answer. See this question now. Again, etiology of schizophrenia, we have discussed, neurotransmitters, again a very important topic. See this question. So, especially I'm discussing this question, when you see such question, you will see, yes, we have discussed these points. All of the following are risk factors of schizophrenia in a female patient, except you have to choose. In fact, we have discussed it with the mnemonic also. So tell me the answer. What is the answer? Winter birth is birth, a child born in a particular month is a risk factor. Maternal stress, stress during pregnancy, yes. Poverty, trauma. So tell me, all are except. Very good. Yes, we have talked about this, when we were discussing. Yes, the answer is C. In fact, we have talked about this, when we discussed risk factors. There are certain risk factors in early development, and then there are certain risk factors in childhood or adolescence, which may increase the risk of schizophrenia. And we have discussed this with the mnemonic also. PSM must. So paternal age more than 60, seasonality of birth, winter, early spring birth, maternal factors, complications during pregnancy, during delivery, infection like influenza during pregnancy may increase the risk. Then migration, urban upbringing, remember, is a risk factor. Substances, very important, such as cannabis, in childhood or adolescence can increase the risk of schizophrenia. Trauma, childhood trauma, social isolation may increase the risk. So remember, in your exams also, in fact, a few exams, one exam which occurred, PSM, it told you it's an important topic. So remember, PSM is must, है ना? PSM is must for your exams, right? So you can remember it with this mnemonic. I hope this is clear to everyone. Yes. Now see this question. So, these are the type of question I told you that they may come in the exam. Questions may be very simple. You just have to, know the concept and you'll answer the question. All are negative symptoms of schizophrenia except. Always make sure that you have read this except also. Sometimes we are in very hurry. We don't, read this except and we mark incorrectly. So tell me what is the right answer here. Just remember the symptoms of schizophrenia. Remember the 5 symptoms of schizophrenia with the mnemonic dhadkan. And, tell me which of the following is not a negative symptom. The correct answer is yes. Disorganized thinking, disorganized speech, disorganized thought, such as loosening of association, derailment, tangentiality, neologism. These are, symptoms of disorganization, disorder of form. Very good. Yes, all of you are correct. So let's just see this. So all of us know this criteria again. I hope we remember delusions, any delusion, any hallucination, disorganized speech, catatonic or disorganized behavior, negative symptom. These are the 5 important. In fact, there are many. These are some of the 5 negative symptoms you can remember. Anhedonia means interest is decreased. Avolition, decrease in willpower. Alogia, logia means word, decrease in speech. Affect blunting or affect flattening, and asociality. So remember, social withdrawal, again it is telling us social withdrawal is asociality. Yes, these are some of the negative symptoms. Thank you. I hope you're preparing well. Right. Thank you for your messages. Now see this, according to DSM-5, out of these 5, at least 2 symptoms should be present. The catch is at least 1 symptom should be from first 3. Okay, remember the mnemonic dhadkan, and at least 1 of them should be from first 3. And what is the duration? We have discussed it is 6 months according to DSM-5. According to ICD-11 it is 1 month. I hope this is clear to everyone. Yes. See this question again. Catatonia is a very important topic. See this, identify the condition. Again, this is a question asked previously. Identify the condition shown in the below given image. Tell me what is the answer. The answer may not be totally correct, but still, if you see the option, you will come to the conclusion. It's not echolalia. Echo means repeat, lalia means word. The person is repeating the same words. Echopraxia, praxia means action, repeating the action. Ataxia, the patient is not able to walk, he's falling. It is out of the option. If you see, it is waxy flexibility, right? Waxy flexibility is the person is bending like a wax candle. You try to move the hand, there is initial resistance like when you bend a wax, but later on it can be bended the way you want. So waxy flexibility out of the options, that would be a better answer. But again, if person is having such abnormal postures, better answer would be, we have discussed all these important catatonic symptoms. Please see, if a person is having such abnormal posture, then better answer might be catalepsy or posturing. Catalepsy is a passive phenomenon. That means person himself has not come into this posture but is maintaining now, and posturing means it's actively, patient himself has come in this posture. ठीक है, देखो इस question में ऐसी कोई option नहीं है, otherwise that would have been a better answer. So please be very careful. You have to choose a best answer from the options given, right? So I hope these catatonic symptoms such as stupor, excitement, mutism, waxy flexibility, negativism, that means patient is doing opposite of what you are telling him to do. You're saying come forward, he is going backward. Automatic obedience is just the opposite. He is, is totally cooperative. He's doing whatever you say. Mannerism, stereotypy, I hope you remember. Both patient is doing some repetitive odd movements again and again. I hope it is clear. Mannerism, the word is telling you that these movements, they have a purpose. They are purposeful, like salute movement. So this has now become repetitive. Now it is mannerism. Echolalia, echopraxia, grimacing, abnormal, odd facial expression. Ambitendency, when the patient is not able to decide what movement to do. His hand is going forward, backward, forward, backward. So these are some of the catatonic symptoms. So quickly we have just discussed. Now tell me the treatment. So when a patient has catatonia, when 3 or more of those symptoms are present, tell me the treatment. Very important. The first line treatment for catatonia. Tell me, can be given IV, sometimes IM or even oral route. You've given one injection. Tell me what is the correct answer here. I hope you remember this. I hope you remember, everyone remembers this now. What is the treatment? Patient has come to us with catatonia. The first line treatment, very good. Please remember, first line treatment will be lorazepam, benzodiazepine like lorazepam. Yes, you know, most effective it is, then you may go with ECT. Yes, electroconvulsive therapy. So first line treatment, remember, it is lorazepam. You know, there is also a test known as lorazepam challenge test. When we are suspecting a patient has catatonia, and we may give a low dose of lorazepam. So lorazepam challenge test can be given. If there is improvement, that again may suggest the patient may be having catatonia. I hope this is clear to everyone, right? Great. So we'll now talk about again a very important topic which you will see, you know, sometimes being asked. It is more of a psychopharmacology topic. You know, we'll talk about antipsychotics. All of us know that we have first generation and second generation antipsychotics. First generation are D2 antagonists, second generation are D2 and 5-HT2A. Both are 2 and A for, remember, atypical. EPS usually more with first generation, less with second generation. Metabolic syndromes such as weight gain, you know, hypertension, diabetes mellitus, these are usually less with first generation and usually more with second generation. I'll discuss, you know, one important interesting question related to this as well. I hope this is clear to everyone. I hope this is clear to everyone. Generally yes, but lorazepam is one of the most common drug we use. Pooja, if again I am again saying first line, then it is lorazepam. If they ask most effective, then you can choose ECT. I hope this is clear. I hope this is clear. Now see this. This is a question, you know, again that halo effect wala question. Again, it is more of a Lorenz effect. Usually don't use this term. You know, patient has come to us with catatonia. Patient is not moving much, and suddenly you have given one drug, and patient has shown drastic improvement. So sometimes it may be compared with effect we see in medicine, that is Lazarus effect. You know, person as if has revived. You know, the person is, you know, you're not seeing signs of life and suddenly the person revives. So sometimes it may be compared, but usually we don't use those terms. Okay, right. See this question now. Patient is diagnosed with schizophrenia, was first started on haloperidol. It's a first generation antipsychotic, thioridazine, another first generation antipsychotic, but not responding to the medication. So he's not showing response. So he was switched to another drug. But after switching, he developed salivation. There is hyaluria. There is hyperglycemia, you can see. So sugar levels are increasing, and also lipid profile has deranged, dyslipidemia. So metabolic side effects have also come. So tell me, what is the drug we have started here? So what is the drug? You know, can you identify this situation? Patient is not responding to 2 or more drugs. Can you identify this situation? Very good. It is treatment resistant schizophrenia. Is not responding to 2 antipsychotics. So the drug which we may start, and also it is matching with the side effects associated with this drug, it is clozapine. Very good. Yes, I hope it is clear, right? So such scenarios we may see. So remember, clozapine is a second generation antipsychotic. See this one more question. In fact, it's a PYQ. Now I'm sure now we can answer this question. We have discussed in great detail about clozapine, right? Which of the following test is done weekly, you know, for a patient who is on clozapine? Tell me the answer. Yes, all of you were correct. It is TRS. Tell me the answer now here. Blood urine nitrogen, ESR, random blood sugar, CBC. What would you do? Tell me what is the... Yes. Tell me the right answer here. Yes, please remember, clozapine requires, you know, again monitoring of the counts. Very important. Yes, you know, absolute neutrophil count, CBC count. You very good. So please remember, you know, all of us know the serious side effects we have been discussing. You can remember with the mnemonic SAM. Seizures can occur, agranulocytosis can occur. You know, please remember, if the WBC, ANC counts they decrease, you know, we have to stop the drug. So that is why we are regularly monitoring these levels, and even myocarditis. You know, please remember, sometimes clinical question may be asked that a patient on clozapine comes with fever, he is having sore throat. So what are you suspecting? You are suspecting some infection. So what you will do? You will check these counts, because again infection may occur because of agranulocytosis, and if the levels are decreased, then we have to stop the drug. One more question. Patient has developed seizure. You know, we may start off thinking an anti-epileptic drug. Which important anti-epileptic drug? You know, many drugs, you know, we may not give with clozapine because of this agranulocytosis. So can you tell me one important drug contraindicated with clozapine? C for clozapine. I've given you a hint. It is an anti-epileptic drug starting with C. Can you tell me? Can you tell me what drug I am talking about, which you should not be, give with clozapine, it also, causes bone marrow suppression. So can you appreciate, again, these side effects can cause even death? Yes. For the first 6 months, every week, we are going to monitor the levels. Yes, very good. Yes. It is carbamazepine. Very good. I hope this is clear. Right. Now see this question. So please be very careful with such question. You will see many such questions being asked again and again. I've been seeing these questions again and again, about the EPS. See this. So there is a 38-year-old female client with a history of chronic schizophrenia. So they mentioned the diagnosis, paranoid type. They have also mentioned the subtype. We know now the subtypes have been removed. Paranoid means delusions, hallucinations are more prominent. Is currently on an outpatient at the local mental health and mental retardation clinic. The client comes in once a week for medication evaluation and or for refills. She self-administers haloperidol. So they mentioned the drug twice a day, and benztropine also. It's an anticholinergic drug she takes, once a day. And during recent clinic visits, she says to the nurse that I can't stay still at night. I toss and turn and can't fall asleep. Can you tell me? Yes, very good. She is having restlessness, and she's tossing and turning. The answer is, it is akathisia. Very good. It is akathisia. Please remember this. So we know, we've been discussing, these important EPS with the mnemonic DP at night. So this A, remember, is akathisia. It is the most common. It is the most common EPS, remember. And what is the, drug of choice if it is asked? Then it is propranolol. Please remember this. Yes, all of you are correct. Yes. See one more question. See this question. A patient is suspected of having NMS. So they mentioned in the question the patient has NMS and who was prescribed an atypical antipsychotic medication, NMS, neuroleptic malignant syndrome. Which of the following medication should the nurse administer to treat this serious adverse effect? So we know it's a serious adverse effect. This term malignant is telling you it is life threatening. So tell me, what is the answer here? Yes, very good. Very good. Yes. Tell me the answer here. Look at the options carefully. They have not mentioned the drug of choice in the option, but still, see the options. What drug would you use? Yes, here from the options it is bromocriptine. Very good. So it is bromocriptine. So please remember, we have discussed NMS. Again, it is a life-threatening condition. Patient comes with antipsychotic, dopamine antagonist drugs, high temperature, increase in the CPK levels, muscle rigidity, sweating, bradycardia, tachycardia, and other symptoms. Even confusion may be there. Okay, there may be increase in the blood pressure. So remember, high temperature, increased CPK, muscle rigidity, again these are pointing towards NMS. Now first step is we have to stop the drug. We have to stop the drug, and the drug of choice you can remember is dantrolene. And again, dopamine agonists like bromocriptine, amantadine, they may be used, which is mentioned in the option. Yes, I hope this is clear to everyone. So just look at these EPS. I'll just briefly discuss. D for, remember, dystonia. It is one of the earliest EPS to occur, sudden contraction of group of muscle. Patient may come like this, torticollis, or there may be uprolling of eyes, oculogyric crisis. Treatment, remember, anticholinergic drugs like promethazine, benztropine. Patient has drug-induced Parkinsonism like tremors, rigidity. There is tremors, rigidity is there. There is bradykinesia. Again, anticholinergic drug like trihexyphenidyl may be used. We have already discussed akathisia. T for, remember, tardive dyskinesia. Tardive means after long-term use. Patient may come with chewing movements, or there is lip smacking movements. So again, we can use drugs like VMAT2 inhibitors, valbenazine, tetrabenazine. I hope this is clear to everyone. A very important table. In fact, see this question again. So many questions have been repeated again and again from this topic. When a patient is administered haloperidol, we know it's a first generation antipsychotic, exhibits involuntary contraction of neck muscles. So there is development of sudden contraction of neck muscles. Tell me, what is this? What is the answer here? Tell me, what is the answer here? It is sudden contraction. We just discussed DP at night. D for, it is dystonia. There is acute dystonia. Very good. Yes. I hope we'll be able to solve these questions. See, one more interesting question. One more interesting side effect. If you remember, in fact, this is a question, I'll say, more of an integrated question. So this question is testing our knowledge of various, topics. So see this question. Which of the following condition is less associated with amenorrhea, cessation of menses? See this. If you know different topics now, sometimes we'll be able to solve. Very good. Now see this question. Yes, that answer was dystonia. See this more interesting. Well, another interesting question. Again, it's a PYQ. That is why I'm saying, you should, have an idea of what type of questions are asked. See this. Amenorrhea, cessation of menses. Is it associated with antipsychotics? Now see this one slide. We know, side effect like EPS and also endocrinal side effect like hyperprolactinemia. It occurs because of the blockage of dopamine receptor. Now in this pathway, tuberoinfundibular pathway, that is from hypothalamus to anterior pituitary, if dopamine is blocked here, so we know in this pathway dopamine is inversely related to prolactin. So by giving antipsychotic, what I have done, we have decreased dopamine levels in this pathway. What will it lead to prolactin? There will be hyperprolactinemia. First very important point, remember, antipsychotics can cause hyperprolactinemia. Compare it with increase in prolactin, just after delivery in the female. There is lactational amenorrhea, there is galactorrhea. Now because of this hyperprolactinemia, one of the important side effects you can remember in females, galactorrhea, milk secretion from the breast, amenorrhea may be occurring, and in both males and females there may also be decrease in libido because of this. So please remember, because of hyperprolactinemia. So first two options, I can say antipsychotics can cause amenorrhea, hyperprolactinemia because of the antipsychotic or because of other reasons can cause. And even in anorexia nervosa, we'll discuss, it was earlier a important core feature which has now been removed from the core criteria list, but still amenorrhea can occur in anorexia nervosa because patient is in a type of state of starvation, तो वहाँ पे भी हो सकता है. So here less obvious answer would be, so better answer in this case would be obesity. Okay, less associated with amenorrhea. I hope this is clear to everyone. Yes, right? So sometimes try to deduce the answer like this and you'll see you'll be able to solve questions. See one more PYQ. Identify the technique shown in the image below. Sometimes such images may be shown and one should know. So can you appreciate, we are giving the injection, intramuscular injection, at 90 degree, and we are also pulling the skin like this so that a track may be formed, so that when we are removing, we remove this hand so that a Z track is formed, so that the drug does not oozes out through this path, through this track. So tell me, what is this technique? Yes, this technique is Z track technique, which is used for IM injection, depot injections. Antipsychotics also may be given by this route. So long acting injectable antipsychotic or depot antipsychotics are also available. These are basically intramuscular injections and can be used in patients. Suppose patient is not taking the oral drug, there is poor compliance, so we may give this depot injection every 15 days or maybe every 1 month or even for a longer time, so we don't have to give the drug regularly. So this is depot antipsychotic. Sometimes we give because the patient preference is also there. The patient says, I'm more comfortable with these depot antipsychotic. Please remember the answer, correct answer is yes, it is D. Very good. I hope this is clear to everyone. Right, so see this question again. Sometimes such questions are asked, so please try to look at such questions and then answer. A nurse is teaching a patient with schizophrenia about how to successfully live independently in the community. Which of the following the nurse should encourage the patient to do? So so that the person is living independently, is able to take care of himself or herself in the community. Very good. Yes, to prevent leakage. Yes, we do that in depot antipsychotic is to prevent the leakage. Because if the drug is leaked, I am giving it for a month, maybe few days before completing 1 month, the effect may go away. So I may know that if I am giving it through this technique, that the exact amount which I have given is reached. I hope this is clear to everyone. Yes. What is the correct answer? To spend time alone? No, will not encourage. Stop medication? No. Again, we know these medication may be given for a longer time, because if I stop in between, there may be chances of relapse. Plan a program for self-fulfillment, that may also be done, but again, not for this. Maybe a long-term goal may be this. Yes, to establish a structured daily routine. Very good. Yes, so we'll encourage the patient. In fact, we use techniques, psychosocial interventions we use, like CBT can be used, token economy. Again, we know, all of us know about token economy, so there are so many interventions in schizophrenia also we have discussed. Psychosocial interventions can be used. So again, we may structure the daily routine of the patient so that he has a daily routine of what he is doing at a fixed time. So yes, that may be a better answer. See this question. Which antipsychotic among the following does not produce weight gain as a side effect? Now all the four we have seen, these are second generation antipsychotics. Can you tell me the right answer here? In fact, clozapine, olanzapine, these are the drugs which have high risk of weight gain. Risperidone also has a moderate risk. What is the right answer here? The correct answer is, remember, it is aripiprazole. Remember aripiprazole, and also one more drug, ziprasidone, A to Z. One of the, some of the drugs, these are second generation drugs which have low risk of weight gain. Also remember, under first generation category, so this is one important drug I want you to remember, that is chlorpromazine. Remember chlorpromazine. It is a first generation antipsychotic. It's a first generation antipsychotic which has a moderate risk of weight gain. Now, can you appreciate, if you are asked, out of aripiprazole or ziprasidone is in the option, and you're asked, one option is chlorpromazine, which has low risk of weight gain. Although, aripiprazole, it's a second generation, chlorpromazine is a first generation, but remember, chlorpromazine has a moderate risk of weight gain. So this is one drug you should remember under the first generation category. I hope this is clear to everyone. Right. Now see this question. What is the role of a nurse when a patient has auditory hallucinations and becomes anxious? So sometimes questions are asked on nursing interventions. What would you do? Sometimes, when you look at the options, the answer would strike. Would you keep the patient in quiet place? The hallucinations, they are occurring because of problem in the brain. Finalize that the patient is seeking attention? No, the patient is not seeking attention. Leave the patient alone? Again, no. Acknowledge that the patient, he can only hear, we cannot hear. It's the patient only who can hear these, voices. So please remember, yes, very good. So some of the interventions, again, we have discussed, especially with symptoms like delusions, hallucination, always assess, have a baseline data about the intensity, content, always try to ask about those details. See if there are any triggers, and if there are any environmental triggers, if possible, to reduce them, we can do that. Try to, communicate with the patient in a very calm and gentle manner. Avoid any arguments. Psychoeducate the patient and family members. And especially, when you're talking about delusion, building trust is very, very important. So keeping the same staff, be very truthful. Don't say that even I can hear the voice, or you start saying that even I think that that person is suspicious. So one should be very truthful and avoid any unnecessary gesture, unnecessary touching, because patient may be suspicious. So these are some more points you can remember. Now see this question. Schizophrenia life expectancy is dash years less than general population. Again, an interesting question. Let me just come to this question. We know that a patient with schizophrenia, because of other reasons, many reasons like suicide. Suicide is one of the causes of premature death in schizophrenia. Even other, things like, remember, cardiovascular disease, even accidents, they may decrease the life expectancy. Remember, in schizophrenia, we see that the life expectancy may reduce by 20%. Okay, so somewhere, again, when we talk about the numbers, somewhere, 16 years, 18 years, different datas may have this. So remember, so see the options. There is only one option, yes. So there is only one option which is matching, yes, around 1 to 20 years. That would be a better answer here. Okay, so remember, there may be reduction of life expectancy in patient with schizophrenia by 20%. And the most common cause of premature death in schizophrenia, remember, suicide. Another important cause is cardiovascular disease, and even other factors like physical, accidents may also cause. So this was about the topic of schizophrenia. Let's discuss some questions from mood disorder. Again, you will see many questions. See this. I hope this question is clear to everyone. Let's come to this question now. A 56-year-old client is admitted to the psychiatric unit in a state of total despair. She feels hopeless and worthless and has very sad appearance, is unable to feel pleasure from anything. Her husband has been assisting her at home with the household cooking, so she's not able to do the work. However, she has not been eating much and lies around or sit in a chair most of the day and is becoming confused and thinks her family does not want her anymore. In assessing the client, the nurse determines her behavior is consistent with. Tell me what is the answer. Yes, so all of us know the symptoms of depression. We know the mnemonic 𝐂𝐡𝐞𝐤, and also remember the duration for making a diagnosis of depression is 2 weeks, right? So when we talk about the severity, yes, all of you are correct. It is severe depression. Very good. So in terms of the number of symptoms, we know that 5 symptoms should be present from the mnemonic 𝐂𝐡𝐞𝐤, right? So number of symptoms are way too much than what is required to make the diagnosis, and also there is severity of symptoms which is causing the functional disability to a much higher degree. Can you appreciate यहाँ पे functioning बहुत ज़्यादा impair हो गई है ना, and there are too many symptoms. So again this is telling me कि यहाँ पे आंसर है severe depression. I hope ये clear है सबको. I hope this is clear to everyone, right? अच्छा, if I ask you which is the key feature of depression, tell me. No, we know how to make a diagnosis, remember? So out of the first two symptoms, sad mood or decreased interest, at least one of them is present, plus 4 or more. So total of 5 symptoms. But if I ask you, अगर मैं आपसे पूछूं key feature of depression क्या है, तो बोलोगे depression is a mood disorder. So key feature depression का क्या है? It is, again you will say low mood. If low mood is not given in the option, then you can say anhedonia. Very good. Then you can say anhedonia. Okay. We'll come to that, but we'll come. Use these days judiciously. You will see that if you are using, अगर आप ये दिन judiciously use करोगे, आप देखोगे जो exam वाले day पे anxiety है वो that will be under control. So even if there is some nervousness, कुछ anxiety, let's keep on focusing every day, one day at a time. तो देखोगे वो जो anxiety build up है वो भी you'll see it is under control. See this. Let's see this question now. Very good. Yes, even hopelessness was there. Yes, very good. Tell me the answer. Again more of a psychopharmacology question. You have to choose selective serotonin reuptake inhibitor. Now we know in depression there is decrease in serotonin, decrease in norepinephrine, two more important neurotransmitters affected in depression. Even you can remember dopamine is reduced. Tell me the SSRIs: escitalopram, fluoxetine, sertraline. So tell me if I am correct, are these three SSRIs which are mentioned in the question? See the question. Yes. So what is amitriptyline? Very good. Yes. What is amitriptyline? The answer is 1, 3 and 4. What is amitriptyline? Very good. I hope all of us have read about those side effects. Please remember the side effects. They can also cause most common long-term side effect क्या है of SSRIs? Tell me. Can you tell me? Let me ask. Tell me most common side effect and tell me the most common long-term side effect. Most common side effect of SSRI? Amitriptyline. Very good. It is a TCA. Yes, all of you are answering it correctly. Yes, very good. I'm seeing your answers. All of you are correct. It's a TCA. Very good. Most common side effect is, remember, nausea. Most common long-term side effect क्या है? Remember, most common long-term side effect, sexual dysfunction. Sexual dysfunctions can occur with the antidepressant like SSRI, other SSRI, antidepressant like even SNRI and other drugs can also cause sexual dysfunction. We'll discuss, 2 important drugs which have less risk of sexual dysfunction as well. I hope this is clear to everyone. Yes. Serotonin syndrome is better when drugs which are increasing serotonin levels, they are, at a toxic level. The serotonin is at a toxic level. So that is known as serotonin syndrome. So if we give drugs, for example, they may give in the question SSRI, TCAs, these increases serotonin if it is too much. Again, how to differentiate? Sometimes you may have to differentiate serotonin syndrome from NMS. First of all, you will see the history. In NMS, they will tell you that there is a dopamine antagonist given, while in the serotonin syndrome, you will see in the history, they will tell you that serotonergic drugs are given. Also remember, in serotonin syndrome, you will see GI effects like diarrhea may be mentioned. So these are some important clues you will see. Myoclonus may be also mentioned in serotonin syndrome. So this may help us differentiate. I hope this is clear. Very good. So it can cause sexual dysfunction like premature ejaculation, like delayed ejaculation, and that is why it may be used in the treatment of premature ejaculation. Yes, you are correct. Now see this question now. A 27-year-old woman with a history of major depressive disorder is brought to the emergency room and she is in a state of confusion, found to have dilated pupils. Very important. So there is mydriasis. Very important. You should know. Try to identify whether it is mentioned miosis or mydriasis. And she has dry mouth, dry warm skin, so the temperature is increased, hypotension is there. ECG is showing QRS duration is prolonged. Tell me which drug may be responsible. So which toxicity? Very good. Yes, Simran. CPK may be increased there. Yes, correct. Can you tell me which drug is responsible here? So can I say it is TCA toxicity? Very good. TCA toxicity, yes. So one of the TCAs which is mentioned, it is imipramine. Very good. Very good. So please remember, it is mydriasis which may be seen in TCA toxicity. Patient develops acidosis. So can you tell me the treatment? Can you tell me the treatment of TCA toxicity, one of the important treatment modalities, patient develops acidosis. So we may do alkalization by. Can you tell me how to treat? Very good. The answer is C. Correct. All of you are correct. Tell me in the management. So the patient may develop acidosis. We may do alkalization by sodium bicarbonate. Very good. Yes. All of you are correct. See this question, a repeatedly asked question again and again in the exam. A client is taking an antidepressant, that is MAO inhibitors. What is the common side effect of this drug with tyramine diet? Tyramine diet, like patient is taking cheese, red wine, beer, so it has tyramine. So tell me what occurs if a patient who is taking MAO inhibitors takes tyramine rich food. Tell me what happens. This question is again and again asked in the exam. There is a hypertensive crisis. Very good, because tyramine is not metabolized because patient is on MAO inhibitors. Tyramine enters the blood. It is sympathetomimetic. It causes, very good. It causes hypertensive crisis, also known as cheese reaction, because again cheese also has tyramine. Treatment again we can do with alpha antagonist like phentolamine. I hope this is clear to everyone. I hope this is clear. Right? Yes. See this question again. So they've just modified this question again. The similar question was asked. A nurse is reinforcing dietary teaching with a client who has new prescription for monoamine oxidase inhibitors, MAO inhibitors. Which of the following foods should the nurse instruct the client to avoid while taking an MAO inhibitor? So the answer again becomes very simple, isn't it? Yes. So what is the right answer here? Can you tell me? Again, the answer is D. So please be very careful. The topics may get repeated again and again. So the question may be new, but you will see the topics may get repeated. Now see another question. See one more question on the drugs. The patient, which antidepressant drug causes priapism? Priapism is prolonged painful erection. Which is the drug which is responsible? What is the answer here? Yes, the answer here, it is trazodone. Correct. The answer is trazodone. Now also remember, so we have been talking about drugs with sexual dysfunction, antidepressant. Now tell me two important drugs which have less sexual side effects. Remember two important drugs which have less sexual side effect, antidepressant. One is bupropion. Bupropion is a one of the drugs. So you may be asked, a patient develops sexual side effects with antidepressant. Which drug now should the patient be switched to? Another one drug you can remember, mirtazapine. These drugs usually have less risk of sexual side effect. I hope this is clear. So I'm just trying to give you some more questions which may be asked like this. I hope this is clear. Let's see this question now. After 3 weeks of treatment, severely depressed client suddenly begins to feel better and starts interacting appropriately with other clients and staff. The nurse knows that this client has an increased risk of what? So can you appreciate, in the initial stage of treatment, and the patient is showing sudden changes, suddenly he's shown improvement, which is one important point. Yes, very good. See this question now. Yes, it is suicide. Very important. Very correct. This is suicide. So please remember, there is something known as paradoxical. There is something known as paradoxical suicide, which we discuss. In paradoxical suicide, what happens? Paradox means patient in the initial stages of treatment or recovery, patient may have increased risk of suicide attempt, because patient, because of the treatment, patient may have gain of energy, but suicidal thoughts are still there. So one has to be very careful, especially in the initial stages of treatment or recovery. So please remember, the answer here is suicide. Correct. Now let's see one more question. Assessment of severe depression in a client reveals feelings of hopelessness, worthlessness, inability to feel pleasure, sleep, psychomotor and dietary alterations are there, delusional thinking is there, negative views about self are there, feelings of abandonment are there. These clinical features of client's depression alert the nurse to prioritize problems and care by addressing which of the following problems first. Please appreciate that other things also we may do, but they are asking you to prioritize, which is very important. Yes, all of you were correct for paradoxical suicide. Very good. Now answer this question. Very good. Now can you appreciate, patient is having some of the risk factors for suicide are present. Patient is having hopelessness, there is inability to feel pleasure, delusional thinking is also developed. So yes, very good. Please remember, possible harm to self may be there. So this is one thing which we need to prioritize. Now tell me the most common psychiatric disorder associated with suicide. I'm sure all of us can answer this is depression. Now we have discussed various risk factors. If I ask you one of the very important risk factors, there are so many risk factors we have discussed. Some of the important risk factors, if I ask, yes, the answer here is C. Tell me some important risk factors. One is history of previous attempt, suicide attempt. Also remember hopelessness. Patient says ki I have no hope for the future. Kal ho na ho, I don't know. So hopelessness again is very important. Again, if you look here, hopelessness is present here, and even other risk factors are also present. So yes, one of the important things you will prioritize is possible harm to self. Very good. Now see this question, a patient has a risk to attempt suicide. The nurse should include which of the following during the assessment of this patient? So they are mentioned. Again, you will see many questions being asked on suicide assessment. So one has to be very careful. We have discussed some important points in the risk assessment. Yes. Umar, not the biggest, but yes, it is one of the risk factors. Yes. One of the important ones, if they ask you, then we have discussed previous history of suicide attempt, very important. Yes, you will ask about family member has attempted suicide, that also may increase. Positive negative thought you will also assess. You will also ask about self image. But yes, very important to ask the patient directly. It's a myth that by asking it may increase such thoughts. No, we will clarify. We will ask about those thoughts. We will ask whether the patient has planned or not. Sometimes we see patient says no, I have not made a plan. Some patient may say I made a plan. So again, if the patient has a plan also, that also may increase the risk. So yes, we'll ask about the suicidal thoughts. Very important. See this. Now see this question. Now let's see some questions on bipolar disorder. Yes, Umar, I got it. Yes. Okay. First year resident, after taking history and interviewing the patient makes the diagnosis of bipolar 2. देखो diagnosis bipolar 2 का है. Bipolar 2 का मतलब क्या है? Simple, that has been asked. Yes, when usually we ask, we start with open-ended question. Yes. Tell me the answer here. What is, so we know bipolar disorder means patient has episodes of depression, mania, hypomania. We know bipolar 1 when patient has at least an episode of mania. What is bipolar 2 disorder? Very good. Bipolar 2 disorder is depression and hypomania. We know how to make a diagnosis of depression. We know how to make a diagnosis of mania. Mania we remember with the mnemonic me dig fast. Duration of mania is 1 week. Duration of hypomania is 4 days. 4 days. I hope this is clear. See this question. Now this question we have discussed so many times. What differentiates mania from hypomania? Again, both have similar symptoms. There may be more than one answer may be correct, but you have to choose one. So what will you choose? Very good. Yes. But depression and hypomania is bipolar 2. Depression and mania is bipolar 1 disorder. Please remember. Tell me the right answer here. See, in fact, all of these may be correct. But if to choose one, then I'll go with psychotic symptoms. Again, there may, other symptom may be there. Hypo means symptoms are similar to mania, but less hypomania, less than mania. Okay, even duration you can remember is less. It is 4 days. So please remember, in hypomania, patient will not have psychotic symptoms. From that mnemonic of me dig fast, usually flight of ideas may not be seen. Need for hospitalization may not be seen. So you can in fact remember this. No, but if you have to choose one, option, then it will be psychotic symptom will not be seen. Usually, if psychotic symptoms are present, then I'll make a diagnosis of mania with psychotic symptoms. Okay, so you can remember this order also. So sometimes you have to choose a better answer. Okay, so please remember, यहाँ पे correct answer is psychotic symptoms. See this. Again, they've been asking such questions. So patient with mania, he is hyperactive. He's not sitting. He's very distractible. He may not be able to sit, and take a full course meal. So what food should be given to the manic patient? Patient is very hyperactive. He requires nutrition also. Patient may get exhausted also. So food which he can keep in his hands, small portions we can give, so that at least he's eating, something. We are able to manage the nutrition. So tell me, finger food, liquid food, solid food, semi-solid and liquid food. Very good. Finger food, small proportions that he can take in his hand, and he may eat in between. Yes, very good, because he's very hyperactive. He may not be able to sit, and complete one entire meal, for a long time. Yes. See this question now. So you are seeing such questions again and again about the nursing intervention. So one has to be very careful. Answer this question. A patient is diagnosed with Bipolar disorder is currently experiencing manic episodes with symptoms of overspending and becomes aggressive when confronted by a colleague. So there is aggression also seen. Which of the following action should be taken by the nurse? Tell patient to relax in the room alone. No, we will not leave this patient alone. Patient is aggressive. What if the person may get hurt himself? Encourage him to take a walk. Again, patient, it may not be possible, the patient may do those things. Now please remember, of course we will allow the patient to express his feelings, but see the option D. Option D is allowed to express aggression freely. No, we will not allow him to express his aggression so freely. No, it may cause harm to self or others. So better answer here would be to limit, to set limits and boundaries. So better answer will be, we may use behavioral interventions. Yes. Now let's see some nursing intervention in malic violent behavior. So very important, low level of stimuli should be there in the environment. Again, the stimuli is high, the patient symptoms may increase. Observation, keep the person under observation, will not keep him alone. Remove any hazardous objects around. Encourage verbal feelings, verbal expression of feelings may be encouraged. Limit setting may be used. One should have very calm attitude. If we are very anxious, that can also escalate the situation. So, speak in a very calm, clear and very direct speech. Keep a staff. Your safety is very, very important as well. So safety again is very important. Okay, and if required, if for the symptoms, so first we'll use, maybe we'll use talk therapy. We'll try to calm the patient down. If that is not working, then maybe we may use medications. Restraint may be the last resort. If we are not able to, do anything, nothing is working and there is imminent harm to self or others, then we may also use restraint if necessary. Okay, but it should not be the first resort. I hope this is clear to everyone. Sometimes such question may be asked, so try to see the options and then answer. See this question. A nurse is assessing a recently admitted client who is exhibiting agitation that appears to be related to acute mania. So again, the patient is having acute mania with agitation. Which action should a nurse plan to utilize when caring for a client expressing agitation related to acute mania? Apply restraints to prevent the client from harming self or others. Again, that may be the last resort. Involve the client in group. No, we'll not be doing group activity in such. We would want less or minimum stimuli around. Leave the patient alone. No, we'll not do that. Maintain a low level of stimuli in the environment. Yes, that may be done initially. Yes. Restraint may be the last thing. You'll not start with restraint. In fact, Mental Health Care Act says if it is, nothing is working, then we may use it. Not as a first step. Yes. Very good. So please be very careful when questions are asked. Now answer this question. A 45-year-old female patient presents with 5 episodes of mania, hypomania, depression in last 1 year with complete recovery in between the episodes. First tell me the diagnosis and then tell me the management. They've asked the management. One patient is having, in 1 year, can you appreciate there are more than 4 or more episodes? Here they are mentioned 5. So what is this? Can you tell me? This is, yes, very good. This is rapid cycling bipolar disorder, and one of the drugs, again, which is preferred here is lamotrigine. Very good. Yes, the right answer here is lamotrigine. I hope this is clear to everyone. Yes, the answer is lamotrigine. Now see this question. What is the rate, suicide rate in India in 2021? We also now have 2022 data, but again it's a PYQ. Sometimes if you just know the value now and you see the option, you will be able to answer it correctly. Okay, now tell me what is the right answer here. What is the right answer here? See, rate of suicide, usually we see number of suicides per 1 lakh population. Okay, so this is usually described in this. So what is the right answer here? Please see this. When we talk about the data which we have of 2022, it is 12.4 per 1 lakh population. Prior to that in 2021 it was 12. So please see this. If you note the data, you see the option, the right answer, isn't it? Please remember. Now also tell me which is the most common method or mode of suicide. Tell me which is the most common method or mode of suicide. Tell me which is the method or mode. So see this, it was 2021, it was 12 beta. It has now, in 2022 we are saying it is increased, 12.4 per 1 lakh population. Right, correct. Most common mode or method, remember, it is hanging followed by poisoning. In India, hanging is the most common method or mode of suicide. I hope this is clear to everyone. Now let's talk about some anxiety disorder. Again, anxiety disorder is a topic you will see, sometimes question being asked. Again, this is a PYQ. This is again a PYQ. Very good. Yes. See, Mr. X does not use a car while going out, scared of using lifts. He avoid going in public places and keeps the door open while he's in a closed room. He finds it uncomfortable to leave the house alone, so he always takes a family member along whenever he goes out. What is the probable diagnosis? क्या diagnosis है यहाँ पे? Please tell me what is the answer here. Very good. Yes. यहाँ पे answer क्या है? Please remember the answer here is it is agoraphobia. In fact, this table we have been discussing again and again. You'll see sometimes, anxiety disorder, I hope all of us understand. Panic disorder is a sudden onset of severe anxiety associated with the feeling of impending doom या fear of dying. Patient को अचानक से ऐसा लग रहा है मुझे कुछ होने वाला है. While we have discussed 3 disorders under phobias, agoraphobia, specific phobia and social phobia. एंड जनरलाइज एंजाइटी का मतलब है अब एंजाइटी जनरलाइज्ड है, कंटिन्यूसली हो रही है. इसमें एक इंपॉर्टेंट पॉइंट रिमेंबर, पेशेंट को एप्रीहेंशन वरीज हो रही है. ओके, सो इन दैट सिचुएशन कैन यू अप्रिशिएट, जब हम बात करते हैं अगोराफोबिया की, हमने डिस्कस किया था कि पेशेंट को एंजाइटी हो रही है 2 और मोर सिचुएशन में, एंड देयर आर सो मेनी सिचुएशन, 5 सिचुएशन DSM-5 में. पब्लिक ट्रांसपोर्ट, ओपन स्पेस, क्लोज स्पेस जैसे लिफ्ट, crowded place here, standing in a line, and last is alone outside. So can you appreciate patient is having anxiety in so many of these situations? The answer is agoraphobia. Again एक recently asked question था, patient को fear है spiders का. There is a fear of spider. Can you tell me उसका आंसर क्या था? हाँ, very good. Patient को specific phobia है. Again, you will see such questions. What is that is known as arachnophobia. Arachnophobia. Again, this is also a PYQ. So please see this. Sometimes, very simple direct questions may be asked. Specific phobia मतलब fear to one thing specific object या situation. Remember acrophobia, height से fear. Claustrophobia, अगर सिर्फ lift से fear है, only one situation, then I'll not choose agoraphobia. Better answer क्या होगा? Specific phobia. Okay. Cynophobia, dogs. Nyctophobia, darkness. So many phobias, remember. Xenophobia, strangers. So many named phobias we have discussed. Very good. And social anxiety disorder, again, sometimes you may be asked questions on social anxiety disorder. Patient को fear है social situation में, कि मैं wedding में, मैं conferences में नहीं जा सकता, मुझे fear anxiety होती है. But actual fear क्या है? कि मैं कुछ ऐसी activities ना करूँ, I may do any activity which may embarrass me in front of others. So ये है social anxiety disorder. So you may be asked a clinical question on social phobia. I hope this is clear to everyone. Right? Now see this. Now again, this is a PYQ. A female patient reports an intense, overwhelming fear of driving a car. The fear has disrupted all the elements of patient's life. The patient does not go to the grocery store unless someone goes along with her, and has relinquished her job and has few social contacts. Can you appreciate, because of this fear the patient is having, so much disruption in functioning. So we know treatment of phobias like, specific phobia, agoraphobia. We know we use behavior therapy. One of behavior therapies. Can you name that behavior therapy? Behavior therapy, because we know that here the patient, what is the problem in the behavior? Patient is not, going to those situations, is avoiding those situations. So can you tell me क्या answer है यहाँ पे? Very good. Systematic desensitization is one of the behavior therapies which we use. One of the therapies which has shown good result with these phobias. Very good. See this question now. So again, I hope anxiety disorder, please try to see the disorder and then try to answer कि क्या diagnosis है. Example of PTSD include all which included. In fact, you have to choose which is included. Example of PTSD syndrome. So now we'll discuss disorder related with trauma or stress. PTSD, post traumatic stress disorder. Trauma के बाद देखो, we know in PTSD and even acute stress disorder, यहाँ पे एक major life threatening trauma होना चाहिए. Like there is an accident, there is war patient has experienced, कोई natural disaster experience किया, कोई life threatening disease, या फिर कोई physical sexual abuse हुआ है. So tell me what is the answer here? The answer here is option B, that is gunshot. Very good. I hope all of us, जैसे re-experiencing symptoms like distressing dreams, flashbacks. Again, these are giving you hints about PTSD. Okay, these are the 4 set of symptoms जो हमने discuss किए. And treatment may remember, what is the treatment? The treatment is CBT. Please remember, treatment is I hope now it is clear. Now it is clear. Let me know. Treatment is CBT. Even EMDR is used, but remember the preferred treatment will be cognitive behavior therapy. I hope it is clear. Now see this, back-to-back questions have come from this topic. Again, a very important topic, OCD. But this is again a very important, you will see, sometimes, some topics may come in the question very simple, and in fact 2 questions came. Last year, a female present with history of frequent hand washing, often to the point of skin irritation. She reports intrusive thoughts about contamination and germs which lead to intense anxiety and distress. बेटा diagnosis बताना है यहाँ पे. हाँ, very good. I hope all of us remember ना, हमने डिटेल में डिस्कस किया with the mnemonic ROSI. There are so many obsessions, so many compulsions we have discussed. Obsession के लिए I told you mnemonic ROSI repetitive होते हैं. Patient's own thoughts, senseless, very important. Patient को पता है that these are senseless thoughts, he wants to resist, but they are irresistible. Okay, and in fact this intrusive thought about contamination, in fact it is the most common obsession. Okay, most common obsession. So this is OCD. See, one more question was asked in the same exam. A patient continually wash his face and wipe it. He knows that he should not do this, so he knows it is senseless, but he cannot stop this act and want to do it again and again. So, but what is the answer again here? Answer again is, tell me the answer again here in this question. So can you appreciate such question may be asked? यहाँ पे answer क्या है? It is, yes, very good. It is OCD. And again we have discussed the types of obsession, types of compulsion. Remember, compulsion like checking, there is washing. So we've discussed all this. Even symmetry, person is arranging things symmetrically. So person is doing something again and again. Yes. See the next question in the management. See the management again. Let me see if we can answer this question. देखो management में of OCD, one is we have drugs, first line drugs, we have SSRI and we have clomipramine. Please see, read this question. Okay, we have first line drugs, clomipramine is a TCA, and then we also have therapy, psychotherapy is also there. Okay, psychotherapy is there. So the question is on therapy. A female having recurrent distressing thoughts of dirt contamination leading to repetitive hand washing. So the diagnosis you have made is OCD. Now tell me the therapy of choice. But a CBT is there and one more option is there. Please see this. CBT is there. Yes, we may use various CBT techniques, and more specific answer is there. ERP is also mentioned. Please remember exposure and response prevention. So we use CBT, techniques like ERP can be used, exposure and response prevention. That is mentioned. More specific answer. Like in that, phobia wala question, agar behavior therapy hai or systematic desensitization hai, we may choose systematic desensitization. So please be very careful. So look all the option. DBT क्या है? We'll discuss. DBT होता है dialectical behavior therapy, जो कहाँ use करते हैं? Disorder जैसे कि borderline personality disorder में. Systematic desensitization अभी हमने discuss किया था specific phobia, agoraphobia में. So better answer यहाँ पे है option C. Now also remember this. We know DSM-5 in even ICD-11 में अब क्या किया है? They made one new diagnosis, obsessive compulsive and related disorder. इसमें important disorder जो DSM-5 में remember OCD, body dysmorphic disorder. पेशेंट को बार बार रिपीटेड प्रीऑक्यूपेशंस हैं कि मेरे बॉडी अपीयरेंस में कुछ डिफेक्ट है. होर्डिंग डिसऑर्डर में पेशेंट बार बार चीज़ों को कलेक्ट कर रहा है, इज होर्डिंग थिंग्स. ट्राइकोटिलोमेनिया, पेशेंट इज पुलिंग द हेयर, गेटिंग रिकरेंट अर्जेस टू पुल द हेयर. एक्सकोरिएशन डिसऑर्डर में पेशेंट स्किन पिकिंग कर रहा है. सो सी दिस क्वेश्चन, you will see topics get repeated sometimes. So most common area affected in trichotillomania. हाँ, very good. Yes, least effective. हाँ, उसमें hoarding. Very good. हाँ बेटा, जो it's a very important modality for management. So many, but remember you should be able to differentiate कि CBT है या behavior therapy है सिर्फ, या सिर्फ cognitive therapy है, या दोनों है. तो CBT. यहाँ पे आंसर क्या है? हाँ, it could be any part of the body, but सबसे common है. It is, please remember, it is the scalp. Now see this question. This is an interesting question. Please have a look at this question and then answer this. A 30-year-old female patient comes to the physician with complaints of having epilepsy. Patient कह रहे हैं मुझे epilepsy, seizure disorder है. For 20 days, these episodes are occurring. ये episode हर रोज हो रहे हैं, occurring every day, and they are occurring at a specific place, office में, where she would have abnormal shaky movements of limbs lasting for 5 to 10 minutes. But usually epilepsy में जो seizures होंगे, you will see they may occur just for few seconds. Of course, if it is not status epilepticus. There is no association, associated loss of consciousness, injury, or loss of bowel or bladder control. She is distressed since she came to know about her father's lung cancer 1 month back. So can you appreciate यहाँ पे they have mentioned a stressor also. Can you tell me the answer here? Can you tell me the answer here? But it does not seem to be a seizure disorder. It seems to be, we have discussed under somatoform and related disorder that patient के symptoms physical हैं but there is no bodily cause. So yes, can you appreciate patient here is having, it appears the patient को pseudo seizures हैं, patient को neurological symptoms हैं. Yes, the answer here is conversion disorder. Very good beta, it is conversion disorder. Somatoform disorder में patient को other system के symptoms हैं, patient को और physical symptoms हैं, maybe of GI. यहाँ पे patient को neurological symptoms हैं, जबकि सोमैटोफॉर्म डिसऑर्डर सोमेटाइजेशन में पेशेंट को और सिस्टम के सिम्टम्स होंगे जैसे जीआई के, सीवीएस के, रेस्पी के. सो प्लीज रिमेंबर हियर इट इज कन्वर्जन डिसऑर्डर. इसको DSM-5 ने नाम दिया है फंक्शनल न्यूरोलॉजिकल सिम्टम डिसऑर्डर. इसमें सेंसरी सिम्टम भी हो सकते हैं, मोटर सिम्टम्स भी हो सकते हैं. पेशेंट कह रहे हैं कि सर आई एम टर्न ब्लाइंड, सडनली उसको ब्लाइंडनेस हो गया. ऑल्सो रिमेंबर, आई वॉन्ट यू टू रिमेंबर दिस वेरी इंपॉर्टेंट टर्म, दिस में भी आस्क्ड कि लाबेलाइन डिफरेंस क्या है. देखो पेशेंट को कुछ सीरियस सिम्टम्स हैं बट पेशेंट मे नॉट केयर अबाउट द सिम्टम्स, एज इफ पेशेंट इज हार्डली केयरिंग अबाउट दो सीरियस सिम्टम्स. इसे कहते हैं ला बेला इंडिफरेंस, केयरलेस एटीट्यूड टुवर्ड सीरियस सिम्टम्स विच मे बी सीन in conversion disorder. I hope this is clear to everyone. A very small important topic, and usually again in the management we may use psychotherapy, like behavior therapy may be used, and other techniques we may use. I hope this is clear to everyone. Now see this, let's discuss this. Now again just some small topics we'll discuss. Alcohol, in fact substance is a topic, please do revise, you will see so many questions. Maximum level of alcoholism legally allowed for driving in India, tell me the answer. I'm sure we have discussed it so many times, hai na? We know alcohol is a seen as depressant. The increasing about blood alcohol concentration again impairs so many functions. So tell me the legal limit. Yes, it is 30 milligram per deciliter. Remember, alcohol is a CNS depressant. This also we have covered. I'll just discuss in the clinical assessment of patient with alcohol use disorder which is not used. Okay, just a small revision, so that you get an idea. We know 𝐂𝐤 questionnaire is very important. We have discussed audit, alcohol use disorder identification test, SADQ, severity of alcohol dependence questionnaire, Fagerstrom, tolerance questionnaire. Fagerstrom test, usually it is used for nicotine, for tobacco. So please remember the right answer here is option A. Now this question, tell me patient experiencing alcohol withdrawal, first symptom that becomes clinically noticeable. Tell me the right answer here. The most common here is, हाँ, very good, वहाँ पे Fagerstrom था. अब यहाँ पे let's come back to this question now. Most common, I hope you remember, we have discussed some important symptoms of alcohol withdrawal. Patient is taking alcohol, suddenly he stops or reduces the amount. So I hope we know all the symptoms of alcohol withdrawal. Yes, first most common you can say, or earliest is tremulousness. Very good. I hope this table is clear to everyone. Patients, alcohol withdrawal symptoms, patient has, let us say, stopped or reduced the amount of alcohol. So I hope all of us remember ना, 6 to 8 hours में tremors हो सकते हैं और symptoms भी हो सकते हैं. 8 to 12 hours में अब patient can have hallucinations like auditory hallucination, even visual, tactile हो सकते हैं. 12 to 24 hours में patient को seizures हो सकते हैं, known as rum fits. Up to 72 hours बेटा delirium tremens हो सकता है. And delirium tremens में again visual hallucination may be more there. Even other hallucinations can also occur. But one of the important points, कैसे identify करोगे delirium tremens का? I hope all of us remember there will be delirium है ना, impairment of consciousness. Please look for those terms which we discuss may suggest impairment of consciousness, जैसे confusion या फिर there is clouding of consciousness, altered sensorium, or they mention disorientation, that may point towards delirium tremens. I hope this is clear to everyone. A very important table. Also now we'll discuss about the treatment. Now when we talk about the treatment of patient with alcohol dependence, so patient may come to us in withdrawal phase, so we will do detoxification. Let's first talk about detoxification and then we'll discuss about the maintenance. Tell me the answer of this question. Very good. All of you are answering superbly. Very good. देखो, a man with a history of alcohol intake presents in hospital with tremors, disorientation is there with auditory hallucination and 2 days after stopping. So patient ko, again he's likely having delirium tremens. On examination patient को hepatomegaly है, deranged LFTs है या icterus है. So they're trying to tell you that there is the liver is compromised. Now we know that benzodiazepines are the drug of choice for managing the withdrawals. देखो यहाँ पे अब ऑप्शंस में सब जगह बेंजोडाइजेपिन मेंशन्ड है, तो क्या चूज करोगे? रिमेंबर लिवर ओके, व्हेन द लिवर इज कॉम्प्रोमाइज वी डिस्कस्ड, सो ऑल ऑफ दीज ड्रग्स वी कैन यूज, इवन डायजेपम, क्लोडाजेपम, बट लिवर ओके is lorazepam and oxazepam. So patient has a liver disease, so we may use these drugs. So we have 2 options with lorazepam. Better answer कौन सा होगा? Better answer along with benzodiazepines, but again we'll also give thiamine. Very good. Thiamine is also added. देखो तो better answer हो जाएगा lorazepam plus thiamine. अगर lorazepam और thiamine अलग अलग ऑप्शन में होता, then I would have again chosen benzodiazepine. Please remember. हाँ, तो withdrawal के लिए drug of choice is benzodiazepine, but we may also add thiamine because patient may be deficient. I hope this is clear to everyone. Now see this question. Now अब हम maintenance में will discuss 2 important drugs. A lady has taken disulfiram for alcohol abuse. ठीक है? Next day on party with friends, she drinks wine and has nausea and vomiting. तो patient को unpleasant symptoms हो गए. After she consumes alcohol, already she is taking disulfiram. तो इसको क्या कहते हैं? Very good. What is the answer of this question now? Very good. This is disulfiram ethanol reaction. Very good. Please remember this. See this slide. So disulfiram is a aversive agent. Mechanism of action you should know. It inhibits the enzyme aldehyde dehydrogenase, ALDH. देखो, जब हम disulfiram देते हैं, we have discussed that it should be started 12 hours after the last drink. Sometimes we say 12 to 24 hours also. ठीक है? क्योंकि अगर पेशेंट ने रिसेंटली लिया है एंड डाइसल्फिराम लेगा तो पेशेंट को डाइसल्फिराम इथेनॉल रिएक्शन हो जाएगा. एंड अगर डाइसल्फिराम हम स्टॉप कर रहे हैं, प्लीज रिमेंबर अप टू 2 वीक्स तक पेशेंट को डाइसल्फिराम अल्कोहल या इथेनॉल रिएक्शन हो सकता है. तो यहाँ पे तो पेशेंट ने नेक्स्ट डे ही कंज्यूम कर लिया, तो पेशेंट को क्या हो गया? डाइसल्फिराम इथेनॉल रिएक्शन. यू शुड ऑल्सो वार्न कि फूड जिसमें लाइक विनेगर या परफ्यूम्स या कप सिरप्स या कोलॉन्स जिसमें अल्कोहल होता है, तो पेशेंट ने अगर वो भी यूज़ किया, सो दैट कैन ऑल्सो cause this disulfiram ethanol reaction which may cause unpleasant symptoms. ऐसा again, so such questions may be framed. Now see this question, it was asked last year. All of the following below are anti-craving agents for alcohol dependence, beta except बताना है. Now I'm sure 2 you can identify. Acamprosate is a NMDA antagonist, and naltrexone is a mu antagonist. Both are FDA approved anti-craving agent for alcohol. Now tell me the answer. Now please remember, no, in fact we have discussed other drugs are also there, such as topiramate can be used, but please remember, lorazepam is not used as a anti-craving agent. It is used for detoxification, for managing the withdrawal. So यहाँ पे आंसर क्या है? देखो, even if you know this ना, the answer is lorazepam. Very good, correct. Now answer this question again. देखो, we have covered withdrawal, we have also covered about the management. Let's also discuss one more topic: alcohol-induced neurocognitive disorder. Wernicke's and Korsakoff in alcoholic patient occur because of beta deficiency of which of the following? Tell me the answer. Correct. Very good. Tell me the right answer. What is the correct answer here? It is because of, very good, deficiency of thiamine, vitamin B1. I hope all of us know the symptoms of Wernicke's. But please understand, ये हो रहे हैं patient may be consuming alcohol and patient may develop these neurocognitive disorders. So remember the mnemonic GOA, global confusion, ophthalmoplegia, ataxia. Korsakoff में remember amnesia होता है, there may be impairment in memory, even confabulation पेशेंट में स्टार्ट हैविंग कॉन्फैबुलेशन, और ट्रीटमेंट क्या होता है, थायमीन की डेफिशिएंसी है, वी गिव थायमीन. सो प्लीज बी वेरी केयरफुल with such question. See this question. A college student was brought to the casualty by his friends after he was found unresponsive in his hostel room. Unresponsive in a state of coma. On examination, respiratory rate has reduced. So there is respiratory depression, even the blood pressure has fallen, and also patient has, please highlight this, pinpoint pupil. Can you see this triad? What is the most likely cause? So can you appreciate यहाँ पे क्या हुआ है? Can anybody tell me what has happened here? So tell me which substance, intoxication. Remember intoxication, very good. The answer is it is because of opioid intoxication. And how will you manage? No, patient is intoxicated with opioid, so we'll use naloxone. We will use naloxone. It is basically, we give it, IV naloxone we use. It is a short acting opioid mu antagonist. Very good. So please remember this. So this is, again a clinical triad of opioid intoxication, respiratory depression. There is pinpoint pupil, coma. Again, remember, meiosis is seen in opioid intoxication. So we know the drug of choice is naloxone. Naloxone. Please remember this. I hope this is clear to everyone. Correct. See this question. This question again was asked. So you will see, sometimes such questions are asked. It was asked last year. Again, a very simple question. If you see the options, a patient has been using opioids for a long time but has now discontinued. The nurse anticipates the use of which of the drug to prevent and reduce the opioid relapse? Now, if you just look at the option, I'm sure the answer is very clear. Very good. That's why I say, see the options and you will be able to get to the right answer. But camproside we have just discussed with alcohol. Haloperidol is an antipsychotic, usually, not used, but it will be used, if there are certain symptoms, like delusions, hallucinations. So what is the answer here? It is buprenorphine. Very good. So we have talked about this, in fact, when we talked about management in opioid. Now let's briefly discuss. We discussed in the detoxification phase, we may use drugs like methadone, which is opioid mu agonist. Buprenorphine, see, norphine rhyming with morphine. It is a partial agonist of mu. And even sometimes we can use symptomatic management like drugs, clonidine can be used. ठीक है, डिटॉक्सिफिकेशन का मतलब विड्रॉल्स हमने ट्रीट किए, और मेंटेनेंस में हम एक स्ट्रैटेजी यूज करते हैं OST, ओपियोइड सब्स्टिट्यूशन थेरेपी, जिसमें कौन सी ड्रग्स यूज करते हैं, यही दो ड्रग्स, मीथाडोन, बुप्रेनॉर्फिन. एंड वन मोर स्ट्रैटेजी वी कैन यूज, हम नैल्ट्रेक्सोन को यूज कर सकते हैं. यहाँ पे हम इसकी एंटागोनिस्ट प्रॉपर्टी को यूज करते हैं. So just have a look at this table. Treatment, in the management of opioid. I hope this is clear to everyone. Right, so detoxification maybe we use methadone, buprenorphine to counter the withdrawal symptoms, and in the maintenance also we can use it in one of the strategies जिसको हम कहते हैं opioid substitution therapy. Now see this question. Which of the following is an example of gateway drug? Again PYQ. But a gateway drug का मतलब है that some drugs may be a gateway, कि patient may in future may use more addictive, more dangerous drugs. So they may be as a gateway. So patient may start with these drugs and may start using the drugs which are more dangerous or more addictive. So कौन सी है इसमें से example of gateway drug? Anybody? Very good. Yes. So please remember, cannabis, alcohol, tobacco. Sometimes you see that patient, they start with these drugs and they may start using some of the other drugs which are more dangerous. Yes. So the answer is all of these are gateway drugs. Very good. See one more question. So you'll get such questions, very recently such questions, I'm discussing have been asked, and you'll see such question. A 12-year-old child is admitted to the psychiatric unit with a diagnosis of oppositional defiant disorder. ODD, we know it's a disruptive disorder of childhood. यहाँ पे patient का negativistic attitude होता है. What should the nurse do to manage his behavior? Should we ignore his behavior to avoid conflict? No, you should not ignore. Allow the child to set his own boundaries. How will he set his own boundaries? Again, allow him, again, not very freely, so we may, set limits, and also we may set rules for his behavior. So we may use some of those techniques in the management, okay, techniques of behavior therapy. So the right answer here is option C. Now, see this, disruptive disorder child. I'll just briefly discuss oppositional defiant disorder. यहाँ पे the child has very negativistic, disobedient या hostile behavior है. टूवर्ड्स अथॉरिटी फिगर, जैसे पेरेंट्स हैं या फिर प्रिंसिपल है, टीचर्स हैं, he may put blame on others, he has done something wrong, वो दूसरों पे ब्लेम कर देगा. बट रिमेंबर द चाइल्ड डू नॉट रिजॉर्ट टू फिजिकल अग्रेशन. डिस्ट्रक्टिव बिहेवियर नहीं होगा, जैसे किसी को हर्ट करना, प्रॉपर्टी डिस्ट्रॉय करना. कैन एनीबडी टेल मी, अगर ये प्रेजेंट है फिजिकल अग्रेशन या डिस्ट्रक्टिव बिहेवियर अगर प्रेजेंट है, तो क्या डायग्नोसिस बनाओगे इन अ चाइल्ड? वेरी गुड, द आंसर देयर वाज सी. कैन एनीबडी टेल मी यहाँ पे डायग्नोसिस क्या बनेगा अगर फिजिकल अग्रेशन या डिस्ट्रक्टिव बिहेवियर है बच्चे में? ओके, वी आर सीइंग कि ओडीडी में नहीं होता. इन ओडीडी दिस बिहेवियर इज नॉट सीन. अगर ये प्रेजेंट है देन विल मेक अ डायग्नोसिस ऑफ कंडक्ट डिसऑर्डर. वेरी गुड. ऑल्सो रिमेंबर इन द मैनेजमेंट ऑफ, वेरी गुड, नहीं बच्चे में विल मेक अ डायग्नोसिस ऑफ बेटा कंडक्ट डिसऑर्डर. इन adult we may think of antisocial personality disorder. Very good, very good. So we may use, you know, again some of these psychosocial interventions in ODD, family intervention. CBT again important, individual psychotherapy may be done. Answer this question, answer this question. Just give me a second. I'll right. So answer this question. All the following are seen in anorexia nervosa. Right, right. So tell me the answer. Now we will discuss few points about eating disorder. Anorexia nervosa में all are seen except, देखो patient in anorexia nervosa, please remember patient in anorexia nervosa, you know, we know these eating disorders like anorexia nervosa, bulimia nervosa are more common in females than males, है ना? So anorexia nervosa में patient is not eating much, restricting food intake. Very important, remember in anorexia nervosa weight or BMI should be low. So patient may be in a state of starvation. So tell me which is not seen. So muscle atrophy can be seen, osteoporosis can occur, electrolyte imbalance, you know, such complications can occur. Usually amenorrhea would be more common. Okay, so please remember, so here the answer is option D. Very good. Now also remember, when we talk about anorexia nervosa, it may have high mortality. Treatment may, hospitalization may be required, you know, to restore nutritional status. Complications जैसे dehydration, electrolyte imbalance, you know, because of decrease in weight by height, we may have to hospitalize. यहाँ पे याद रखना है, management में CBT is one of the preferred modality. We may use drugs like SSRIs also. ठीक है, we will discuss. Heartiest congratulations beta, heartiest congratulations Neer. Right now देखो, I'll ask one question कि there is, you know, we are admitting a patient giving adequate calories but patient का weight increase नहीं हुआ, तो next step क्या करेंगे बेटा? Please remember, we know even anorexia nervosa में भी एक restrictive type होता है और एक binge eating purging type होता है, तो वहाँ पे भी binge eating purging हो सकता है. तो ऐसे सिनारियो में हम patient को observe करेंगे 2 hours after each meal. What if patient after each meal is using compensatory behaviors? I hope this is clear to everyone. I hope this is clear to everyone. Right, now see this question. देखो again, this question was asked previously. A 16-year-old client with anorexia nervosa, देखो, you will see many questions like this, is on inpatient psychiatric unit. She has a fear of gaining weight and is refusing to eat sufficient amount to maintain the body weight for height, age and stature. To assist with the problem of powerlessness and plan for client to no longer need to withhold food to feel in control, the nurse uses the following strategy. Very good, but please be very careful. You will see such nursing interventions. देखो, distract the client, option B doesn't seem to be the correct answer, है ना? Distract the patient client during meals to get her to eat because she must take in sufficient amount. So by distracting we may not be able to, you know, achieve much. Do frequent room checks to be sure that client is not hiding food or throwing it away. We, you know, again, not, you know, one of the first thing we'll do. See this, A or D. देखो, we discussed CBT, we discussed not CBT is a preferred treatment. देखो, we will establish a structured environment with routine tasks that can be done, also serve meals at same time. But again, that may not encourage the patient to start eating. isn't it? Because patient, sometimes it may be forcefully given, then also patient is refusing. So that may be done, but again, more priority. See the option D, listen attentively, participate in in-depth discussion about food, because these actions may encourage her to eat. CBT, what we do in CBT, cognitive behavior therapy, there is a negative cognition. Patient thinks that she'll gain weight after eating. There is a fear of gaining weight. So can I say, first thing is, yes. So please remember, sometimes the treatment, you may have to apply like this, but please be very careful. That is why I'm saying, you may also think of doing A option also, but then that may not be so much fruitful, because again we have to again work on the cognition of the patient. Patient की thinking ऐसी है ना, patient को लग रहा है कि I am fat, perceiving herself to be obese, ऐसा patient perceive कर रहा है. So there is disturbance of body image. So we are trying to change the thinking. Right, very good. So please remember, I'll just discuss some nursing interventions also, but especially we are dealing with cases like anorexia, eating disorder. Maintain input output chart, very important. Especially पेशेंट को कॉम्प्लिकेशन जैसे डिहाइड्रेशन हो सकता है, तो स्किन ओरल म्यूकस मेम्ब्रेन मॉनिटर करना है. फोकस ऑन वेट गेन, करेक्टिंग न्यूट्रिशनल डेफिशिएंसीज, वेट मॉनिटरिंग. Severe cases में even the nasogastric feeding may be done, and also in these patients you may see suicide risk may be there, so that also needs to be done. I hope this is clear to everyone. See this question. A girl child eats food, burger at one go, so she is eating a lot, and then after eating too much she induces forceful vomiting. So there is binge eating followed by purging, and in the question they mentioned BMI is increased, it is high. So can you tell me what is the diagnosis here? Please remember, binge eating, purging, ये anorexia nervosa में भी हो सकती है, but वहाँ पे they will mention BMI is low. Here they mention BMI is increased. It may be increased or it may be normal. तो यहाँ पे आंसर क्या है बेटा? बुलिमिया नर्वोसा. Very good. Please remember, it is not always कि patient compensate करेगा हमेशा by forceful vomiting. Patient can use other methods of compensation. Don't think हमेशा it will be just forceful vomiting. Patient may use drugs like emetics, diuretics. Patient may do excessive exercise. Patient may do binge eating, and patient may do dieting for some days. So don't think कि ये बुलिमिया नहीं होगा. So don't think कि it is always forceful vomiting. It can be other methods also. ठीक है? So it is bulimia nervosa. Very good. See this question again. Again, this question was asked in 2024. Miss Salima, 24-year-old female, comes with complaint of binge eating followed by self-induced nausea and vomiting. Okay, it seems to be, again it can be an anorexia also, seems to be, could be bulimia nervosa. So, seems to be bulimia nervosa here, let us say. What is the reason for this effect? Why is she doing self-induced vomiting? Tell me the right answer here. कि self-induced vomiting patient क्यों कर रहा है? Binge eating gives pleasure? No, it does not give pleasure. Thinking that binge eating has no health effect? No. Patient many times know that it can have health consequences. In fact, there are complications we have discussed like metabolic alkalosis. I hope everybody remembers now. Metabolic alkalosis can occur because HCl is going out, right? So patient may have again decrease in the potassium, sodium and chloride ions may be reduced. So you may get such complications. Russell sign, if you remember, callus on the knuckles because of repeated injury. Okay, binge eating occurs due to social pressure? No, again, so because of fear of weight gain and becoming overweight. Here also this fear may occur, which may lead to these behaviors like self-induced vomiting. Very good. The correct answer is A. Now this, I'm sure again such questions have been asked. They've asked both. Transference भी पूछा है एक बार, counter transference also they've asked. So when a patient emotionally transfers feelings from past relationship onto the therapist, तो इसको क्या कहते हैं? Can anybody tell me what is the answer here? Feelings of the patient towards the therapist. What is this known as? This is known as transference. But a counter transference होता है when the therapist or the nurse, they develop feelings. When the therapist or let us say the nursing officer, they develop feelings towards the patient, उसको कहते हैं counter transference. यहाँ पे answer है transference. I hope this is clear to everyone. See this question. We have talked about psychosexual stages of development given by Sigmund Freud. So tell me, in which of the following stages of psychosexual development child begins to explore their genitals? Please remember, so we know there are 5 stages. I hope all of us know: oral, anal, phallic, latent and genital. So tell me what is the right answer here. What is the right answer? But sublimation is a defense mechanism. Sublimation is a defense mechanism. Patient अपने inner conflicts को socially acceptable behavior में convert करता है, उसे कहते हैं sublimation. जैसे बच्चे को गुस्सा आया, he goes and scores a century in the cricket match, तो अपने एंगर को, इनर कॉन्फ्लिक्ट को उसने कन्वर्ट कर दिया सोशली एक्सेप्टेबल बिहेवियर में. यहाँ पे करेक्ट आंसर है बेटा यस, इट इज फैलिक. ये है फैलिक. यहाँ पे आप देखोगे चिल्ड्रन इन द फैलिक स्टेज दे में एक्सप्लोर, दे में बिगिन टू एक्सप्लोर देयर जेनिटल्स. सो प्लीज रिमेंबर यहाँ पे आंसर है इट इज फैलिक स्टेज. अच्छा टेल मी fixation in which stage causes OCD? So these are the 5 stages ना according to Sigmund Freud. We may pass through. Tell me किस stage की fixation में OCD हो सकता है? OCD occurs, write down the name. OCD may occur in the fixation of which stage? OCD, please remember anal stage. You know, Oedipus Electra complex may occur in phallic stage. So remember some of these points. Okay, right. Now see this question. Projective technique is used to assess. So we know there are certain projective tests now. So before answering, you can see these projective tests. Rorschach test. We give such ink blocks to the patient. या फिर thematic apperception test, TAT. Patient को हम Rorschach test में पूछते हैं उसको what he is able to identify in this ink blot. Thematic apperception test में we ask the patient to make a story. So we may use projective test for what? Can anybody tell me? Yes. So these are basically used for personality assessment. Very good. So answer is option D. Now see some questions on ECT now. Now ECT is a topic, again you will see many questions. Let's come to some topics on ECT. I think 10-15 minutes more and then we'll stop. Hai na? So we'll cover some of the remaining topics. A nurse administers pure oxygen to a client. You might have seen, oxygenation is done after ECT. What is the nurse rationale for this procedure? We know ECT is direct and indirect now. Now in India we use modified or indirect ECT. है ना? Indirect ECT का मतलब क्या है? We use muscle relaxant and anesthesia. है ना? Under anesthetic agent we do ECT now. So tell me, so why are we giving oxygenation? Yes, because we are giving muscle relaxants, we are giving anesthesia. So to prevent anoxia due to medication induced paralysis of the respiratory muscles. Very good. I hope this is clear. So we know that we have two types. So in the pre-medication we have discussed, except during the electrical stimulation, 100% oxygen is administered until patient को spontaneous respiration शुरू होता है. You'll see then we may stop. So otherwise you'll see during pre, in the pre-medication and even after giving the ECT we give oxygen is administered. Okay, and that was the question asked. Now let's see another question. A patient, again it's a PYQ. It's a PYQ. A patient is administered 𝐂𝐸𝐈𝐼𝐶 chloride prior to receiving ECT. What is the primary reason for administering this medication? So why are we giving 𝐶𝐸𝐈𝐼𝐶? Anybody? Tell me what is the reason to give? To induce anesthetic effects, to decrease gastric secretions, to decrease anxiety, or for muscle relaxation? क्यों दे रहे हैं 𝐶𝐸𝐈𝐼𝐶? Why are we giving? Very good. Yes, for muscle relaxation. Very good. So again we give 𝐶𝐸𝐈𝐼𝐶 for muscle relaxation. Very good. And also remember to decrease some of the secretions, muscarinic anticholinergic drugs like atropine, glycopyrrolate, they may be given to minimize oral or respiratory secretion. But we are giving 𝐶𝐸𝐈𝐼𝐶, we discussed, we give anesthesia and muscle relaxant for muscle relaxation. Very good, very correct. I'm very happy you are answering it correctly. Also we may use anesthetic agents, like the most commonly used anesthetic agent, remember, is methotrexate. Other anesthetic agents we have discussed, you can remember it with the mnemonic METCAP we have discussed. So these are some of the anesthetic agents which may be used, but सबसे common हम कौन सा use करते हैं? Remember it is methotrexate. और सबसे common muscle relaxant हम कौन सा use करते हैं? Remember it is 𝐶𝐸𝐈𝐼𝐶. I hope this is clear to everyone. इसे हम कहते हैं modified या indirect ECT. Is it clear? Right. Very good. So we have discussed again why we are giving muscle relaxant, because patient में sustain injury, patient is, we are inducing seizure, so patient can have fractures, there may be dislocations, so we're giving muscle relaxant. Again, the experience may be very horrific for the patient, so we are also giving anesthesia. So please remember, India may, according to Mental Health Care Act, we cannot give direct ECT. We always now use modified ECT. Okay. Now see this question. Now even about the post ECT care question may be asked. A patient has just received ECT treatment. You might have seen, patient has received ECT. Which of the following should be immediately addressed by the nurse in the post ECT recovery period? Tell me what is the right answer here. Observe signs of suicidal thoughts, excessive sleepiness, orient the patient, monitor vital signs. We may do all, but सबसे important अभी क्या है? You have to choose one. Before, again, of course, we'll start orientation, but very important is we'll monitor vital signs. Very, very important. But yes, we will also orient the patient. We'll start orienting, but first, very important is monitor vital signs. So it's very important in the post ECT care. Some of the important points you can remember: monitor the vital signs, continue oxygen. Oxygenation till spontaneous respiration starts. Assess for post-ictal confusion, restlessness. Yes, you will, assess ki orient, the patient may be confused. You may also orient the patient. Safety procedures are also very important. You raise the rails, side rails. Also, you will start reorienting. But very important is, if monitoring vital signs is there, that is a better answer. Yes, of course, then we'll also orient the patient. Okay, so please see the options carefully and then try to judge which would be a better answer. Great. I hope this is clear. Now look at this question also. A patient has just awakened from ECT treatment. So patient is awakened. Most appropriate action at this time now. Observe for signs of suicidal thoughts. We may do it, again, depending what was the case, what was the scenario. Look for delusion, orient the patient, arrange for diet to be served. Now you can see. Now can you appreciate this question mein kya answer hoga? Now very good. Yes. Now you can, choose orient the patient. Correct. Very good. So please look at the options carefully and then try to answer. Right? I hope this is clear. Now see this question. Achha, it is not a question on ECT, but again, very interesting question. During a therapy, patient is asked to do smoking while giving mild ECT. So we are just giving mild electric shock. We are not inducing seizure. When patient is smoking, we give an electric shock to create unpleasant effect associated with smoking. And patient now feels repelled from smoking. Can you tell me what is this therapy? We know so many behavior therapies we have discussed. One of this is a behavior therapy. Yes, what is this? Aversion therapy. What we are doing, we are giving a noxious stimulus, isn't it? Jaise disulfiram is an aversive agent, it was causing unpleasant symptom. Yahan pe, again, it is not a very common method we use, but sometimes for substance, even for paraphilias, studies have been done for aversion therapy. So noxious, so what is happening? We are trying to associate ki jab bhi patient smokes, we give a mild shock. So he starts thinking that it is giving me unpleasant effects, and patient may stop smoking. Very good. It is aversion therapy. Now see this question. Now I'll discuss some questions on even personality disorder. You'll see some questions being asked. A nurse is caring for a patient with paranoid personality disorder. The nurse should do which of the following to control? I hope all of us know the clusters of personality disorder na. देखो, paranoid personality disorder na, patient is very suspicious. Patient is not able to trust. So, again, controlling the limits of his behavior, giving more attention may prove detrimental for a good rapport. So please remember, we allow the patient to express himself or herself. Building trust is very important in these patients in the management. In fact, I hope all of us know these personality disorders na. Cluster A, cluster B, cluster C, ये तीन personality disorder ना. A में paranoid, suspicious, remember. Schizoid, socially withdrawn है. Schizotypal may have very odd thinking, odd behavior. Okay. And cluster B में antisocial, name is telling us ना, antisocial, violating rights of others. Borderline I'll discuss. Histrionic में attention, patient is seeking attention. Narcissistic में patient को लगता है I am more important. Cluster C में avoidant, patient avoid करता है situations को. He thinks that I am socially inept. Patient has anxiety, also known as anxious personality disorder. Dependent में patient depends on small decisions on others. And OCPD में patient wants to do things, following all the rules, सब regulations को follow करना है. So these are the three clusters. I just briefly discussed so that you know. W, you know, A say remember weird, you know, one W you can remember wild, and one W you can remember worried. So just briefly discuss, you know, those of you have not read, so that you have get an idea. Let me come to the questions. Now, which of the following is not a symptom of borderline personality disorder? ना, borderline personality disorder is a cluster B, more common in females than males. इसमें क्या नहीं होता? So tell me what is the answer here? So again, you will see some PYQs. You know, you will see many, you know, few questions being asked on personality disorder also. And either they have asked to make a diagnosis or they have asked about the management. So usually management of all these personality disorders, therapy is preferred. Tell me यहाँ पे आंसर क्या है बेटा? बॉर्डरलाइन में क्या नहीं मिलेगा? देखो, recurrent suicidal thoughts we know ना, unstable relationship, hopelessness may occur, impulsivity usually you will see, high self-esteem usually is not seen. Yes, and one important therapy remember for borderline personality disorder is dialectical behavior therapy, DBT. Very good. So you know, remember this very important point. Now see one more question. It in fact was asked last year. Again, very simple question. You know, that is why I'm saying, you know, sometimes such questions are asked, try to see the option and you will come to the answer. Person has dependent personality disorder. What can be seen in future? Less social interaction, unable to make decisions without advice, taking responsibility, able to make relationships. Can you appreciate? Name is telling you, na? Patient is dependent on small decisions, everyday decisions on others. Very good. So tell me what is the right answer. Less social interaction will be more of a feature of schizoid personality disorder. Patient will not be able to take responsibility or may not be able to make relationship. Patient would depend on others. You know, patient would depend on small decisions. What should I eat today? What should I wear today? Let me ask my mother. Let me ask my friend. So small daily decisions. Patient depends on others. I hope this is clear to everyone. Now see this question. Again, it's a PYQ. A psychiatric mental health nurse is teaching a couple how to use positive reinforcement technique with their child. So you have to just see ki isme which is suggesting positive reinforcement. Now please remember, when we talk about reinforcement ना, दोनों positive और negative reinforcement दोनों का मतलब होता है increase in the frequency of behavior. Can anybody tell me? हाँ. Can anybody tell me what is the right answer here? Agreeing with child's statement, whether negative or positive, and simply restate no. Control the child behavior so there is no chance of negative behavior. No. Removing adverse consequences to produce positive consequences. This is more suggestive of a negative reinforcement. Rewarding, yes. Positive reinforcement का मतलब है reward करना. You know, so suppose child studies well, so we give a reward. Let us say we give a toffee or chocolate so that the child will study more. ये है positive reinforcement. Negative reinforcement का मतलब है, you know, to avoid that negative consequences. हो सकता है to avoid failing or to avoid scolding from the parents, so the child increases the behavior of studying. So reinforcement का मतलब होता है behavior increase होना, दोनों में, positive में भी और negative में भी. तो यहाँ पे आंसर है ऑप्शन डी. Answer this. During a therapy, patient is asked, okay, this I think we've solved, already solved. See this. Which of the following scale is used for OCD? Now please remember, sometimes you may be asked about the scale. So I'll discuss some of the scales. You know, we already know many of those scales. You know, sometimes even if you don't know, just try to rule out the other options. You'll get to the answer. Punishment we do to decrease the behavior. Very good. So punishment we do to decrease the behavior. Very good. देखो, PANSS पॉजिटिव एंड नेगेटिव सिंड्रोम स्केल. पॉजिटिव नेगेटिव सिम्टम किस में होते हैं? स्किज़ोफ्रेनिया में. यू नो, BPRS, brief psychiatric rating scale, again can be used for psychotic disorders. HAM-D, Hamilton rating scale for depression, also, you know, sometimes say HAM-D. Okay, Hamilton depression rating scale. Yes. NIMH, see this, you know, even if you don't know this, global OC, obsessive compulsive, you know, symptoms. So please remember NIMH, GOCS, it is for OCD. So just remember some of these scales. PANSS, BPRS, you know, may be used for psychotic disorders. HAM-D, D, depression, Beck depression inventory, even MAD, MADRS, that is Montgomery Asberg depression rating scale. Young mania rating scale, Young mania rating scale. So the name is telling you YMRS. It is again for, it is for mania. Very good. Y-box, Yales Brown obsessive compulsive scale. confusion, see this name, confusion assessment method. Can you appreciate from the name? Confusion है ना, तो ये कहाँ पे यूज करते हैं? डिलीरियम में. वी नो डिलीरियम में confusion हो सकता है. मिनी मेंटल state examination, we may use it for cognitive function, so it may be used in conditions like dementia. Please remember, MMSC is a screening tool we use for assessing cognitive function, or MSc, mental state examination, is actually the name given to when we assess or interview a patient with psychiatric problems. And Hindi version of MMSc is HMSc, Hindi mental state examination, by Ganglu et al. So these were some of the scales which we have discussed. हाँ, just have an idea. But again I'm saying, आप जब MCQ solve करोगे, you see the scales name and you'll be able to come to the answer. So that is I'm saying, just have an idea about some of these scales, about some of these. Very good. I hope this is clear to everyone. Right now, so this was about today's discussion. You know, I hope you're preparing well. Take one day at a time. Again I'll say, very very important. You know, take one session at a time. You know, so again, one of, you know, few things which we should do, try to take one day at a time. Don't think too much about that exam. Okay, take one day at a time. You know, make your schedule, try to, you know, revise things. You know, few things if left, you know, continue with your schedule. Read important topics, read, you know, see the PYQs, you know, the whatever the faculties have told, you know, try to follow all those, try to revise all the important topics of different subjects. Okay, and during the exam day, again, you know, try to have a good sleep. रात को सो के अच्छी तरह जाना है for that exam on the next day. Okay, and also when you're giving the exam, try to be relaxed, you know, have a good breakfast also. Okay, and also when you are giving the question, okay, but please focus on one question at a time. एक बार आपने क्वेश्चन अटेम्प्ट किया, सारे ऑप्शन ठीक से रीड करने हैं. सो फ्यू टिप्स आई विल शेयर. यू नो दैट लुक फॉर कीवर्ड्स, जैसे ड्यूरेशन साइकाइट्री में इंपॉर्टेंट है, कीवर्ड है. यू नो सम सिम्टम्स विल बी कीवर्ड्स. ओके, देन ऑलवेज रीड द लास्ट लाइन वेरी केयरफुली. आप देखोगे कभी कभी लास्ट लाइन विल सॉल्व द पर्पस. एंड रीड क्वेश्चन केयरफुली. कभी कभी क्वेश्चन होता है ऑल आर ट्रू एक्सेप्ट, हम वो एक्सेप्ट मिस कर देते हैं. रीड ऑल द ऑप्शंस केयरफुली, बिकॉज समटाइम्स हो सकता है 2-3 ऑप्शंस करेक्ट हो. यू हैव टू चूज अ बेटर आंसर. when you are giving the paper, you know, try to use certain strategies, जैसे rule out करके देखो. but exam time पे अपने आपको over ज़्यादा analyze नहीं करना है. no, take one question at a time, and during the preparation time है ना, अभी take one session at a time, focus on one subject, one topic, and you will do well, है ना. again remember, keep smiling, keep moving forward. again thank you so much, all the very best, है ना, and I hope all of you clear this exam. Thank you so much.